السلام عليكم يا سامح، ازيك؟
عليكم السلام، ازيك يا باشا؟ اخبارك ايه؟
كله تمام، ازيك عامل ايه؟
يا باشا الحمد
الصوت
لله.
كويس كده يا سامح؟
ايوه كده احسن يا باشا، احسن من المره اللي فاتت كتير.
طب تمام، هو انا ما عملتش اي حاجه.
سبحان الله يا باشا.
ايه الاخبار؟ انا شايف دكتور شريف الغمري، كل سنه وحضرتك طيب يا دكتور شريف. ويعني سامح، انت هتعمل لي كو هوست معاك؟
ثانيه واحده يا باشا، حاضر.
جون بولينا اول واحد. ترانسبسوس.
تمام يا باشا. احنا هنبدا يا باشا ان شاء الله الساعه 3 الا 5.
اه.
هو بس كريستيان عنده emergency surgery،
كريستيان
فاحنا
ده؟
هنأجل محاضرته ده.
اه ده.
هنأجل محاضرته
ايه؟
هنأجل محاضرته للآخر.
اه. بعد تيودور.
اه ان شاء الله يا باشا، لو قدر يجي هيجي، معلش بقى هنقفل السيشن على كده ان شاء الله.
ماشي. هو كريستيان كان هيقول ايه؟ كان هيقول surgery around cervical thoracic junction.
يس.
مم. خلاص انا هقدم جون بولينا والان ليفي. ماشي.
تمام يا باشا، اوكي.
وبعد كده تقدم انت جون شين ونادر.
اوكي
خلاص.
تمام.
جون شين ونادر، وبعد كده انا اقدم نيكولاس تيودور.
تمام كده يا باشا.
ماشي.
اوكي.
وانت هتقدم في النص بقى ايه؟ نادر واللي هو جون. ولو جه في الاخر كريستيان تقدمه انت.
اوكي.
انت هتخلي البانل ليست مين؟ هتقول لو دخل.
اه ان شاء الله. والدكتور وفا
ماشي.
زي ما حضرتك تحب بعد كده بقى. شوف حضرتك إيه. 5 minutes to start. Professor Bolina, nice to meet you, sir.
Very nice to meet everybody, actually. I'm looking forward to the opportunity to talk about what we've been working on here in Buffalo.
Thank you, sir, for accepting our invitation.
You're welcome. Thank you for inviting me again.
Professor Bolina, you can start sharing your screen.
So,
سامح انت الاول كنت رحب بالناس اما يدخلوا كلهم وبعدين
باشا هو تيست
تمام.
Well, he was just trying to, because I kept setting, I told him that you want to try to see if the sharing screen is good or not.
yeah, looks good, right?
Two minutes to start.
Hi, how are you? Hello, everybody. Dr. Polina, nice to meet you. Hi, John Shen. How are you?
Well, nice to meet you too, Mohammed. Really appreciate the opportunity to speak in front of everybody today.
It is our great pleasure actually to have all of you between us, and we hope this global pandemic fade rapidly and so we can meet physically again, inshallah.
Yes, I very much look forward to that.
I think it will run, we'll start by introduction from Sameh, then we will go through our scheduled lectures according to the scheduled program. So we will have these nice updates in spine surgery. At the end of each lecture, we can have some questions from the panels, or we can have some questions and answers from the participant as well. That will be great if we can finish in proper time, because it is really well prepared, top-notch webinar. I can see amazing titles of lectures actually with amazing faculty.
Okay, sir. We will start now. At the beginning, I'd like to welcome all professors attendees and eminent speakers that have accepted our invitation to give us their experience about updates on spine surgery. AWNC Academy is an online academy pioneer in learning of neurosurgery. For more than 5 years, we have till now 30,000 attendees and members. We done till now eight webinars, attendees and views till now 22,000. I'd like to thank dear colleague Dr. Muhammad Sulaiman, who has put all these eminent speakers and lectures together, and we will start our welcoming of speakers, then start our celebration. Thank you.
Thank you, Dr. Sameh, for your efforts and your team in the Egyptian and World Neurosurgery Community Academy for their enthusiasm to spread and exchange knowledge between spine practitioners all over the world. Today, it is actually, in particular, we can say it is Meet the Masters. It is update session in spine surgery. You can have keynote lecture about the engineering in spine surgery. You can have some new techniques like prone position in the for transpsoas approach for degenerative lumbar spine. You can have some new techniques and the new message for the intradural pathology. You will hear some tips and tricks regarding the cervicothoracic and the craniovertebral junctional pathology and approaches. Plus, of course, all through this webinar, you can have interactive questions and answers, which can help you a lot to improve your skills and improve your knowledge in spine. And we'll start actually this webinar by Dr. John Polina. Dr. John Polina, Associate Professor of Neurosurgical Surgery at the State University of New York. He's one of the pioneers in spine surgery in USA, and he will give us his lecture regarding the prone transpsoas surgery for degenerative lumbar spine. Dr. John Polina, can you share your screen and we can start our nice webinar?
Thank you very much.
Yes, yeah. Yes, let me just get that and share. Great, there we go. Well, thank you again. It's an honor and privilege to spend time with all the participants today in talking about a very novel approach to the lumbar spine that's rapidly gaining sort of acceptance and popularity here in the United States. And I want to start by saying that the prone transpsoas approach, or the PTP, is a distinct procedure from traditional or more commonly seen lateral transpsoas approach. And we'll talk about why that is and the advantages that the prone transpsoas approach has in and of itself, and the differences specific to it when you compare lateral transpsoas surgery. Let's see. Here's my disclosures. So lateral transpsoas or interbody fusion has a long history. I began doing this procedure back in the early 2000s, and that middle slide here, this X-ray, was one of my early cases where we used a cylindrical threaded cage. We did a very large incision and opened the psoas by hand and placed these cylindrical cages laterally without any monitoring, without any significant difference in implants that we were using, doing anterior surgery or posterior surgery, and basically took those techniques, or I should say those instruments and implants, and use them in the lateral approach. And while it was a good idea wasn't a great idea. We had certainly some difficulties early on for a variety of reasons. Here you can see quite a bit of subsidence with the cage. There was neurologic issues because of lack of ability to monitor during the case. And this led to kind of an evolution in research into how to do this procedure more reliably, validate the procedure, do it more safely. There were some attempts to try things in front of the psoas or anti-psoas. There were some endoscopic approaches that were attempted, all of which didn't have really great outcomes or satisfactory radiographs. It wasn't until the early 2000s, and I give credit mostly to Dr. Pimenta, who began to validate the procedure in and of itself, primarily because of his ability to integrate the neuromonitoring with the procedure and then develop implants specific to the procedure. And it was at that point in the early 2000s, mid 2000s, the procedure began to gain acceptance because we can do it in a minimally invasive way, very reliably, validate the procedure in terms of its outcome, and do it, most importantly, very safely because of the integrated monitoring that was able to be done. And since this time, there's been tons of literature. I mean, you can just go on Google Scholar and you can get tons of many papers that'll validate and show how safe the procedure can be done, the outcomes, the expected complications. And really, I think over the last 20 years, it's gained acceptance as to be a valid tool that a spine surgeon can use in treating most spinal pathologies. And there's lots of advantages to it. And again, the literature is full of this, in regards to the advantages the lateral transpsoas approach has compared to more traditional posterior or even anterior approaches. And we all know what those advantages are. There's less blood loss, there's less infection rate, there's less use of intensive care. We see shorter hospitalizations, quicker recovery for our patients. And this is largely because of it's a muscle preserving or anatomy preserving, I should say muscle splitting, anatomy preserving approach. There's less bone work. We don't strip muscles off the spine. So there's a lot of advantages that we see with this MIS lateral technique that we can take advantage of for the patients that result in, some improved outcome measures when we look at it. The other advantages are biomechanical. When we do lateral interbody placement of an implant, it's a much more biomechanically stable or stiff construct. And the picture here on the left shows why. The implant is much larger. It sits on the cortical apophyseal ring, which gives it a much stiffer sort of bone implant interface. And when you compare the fusion surfaces of a direct anterior or a PLIF or a TLIF, you can see the advantages that the biomechanical advantages the lateral interbody approach has, just by the implant footprint that's we're able to use. And this allows for a more optimal fusion environment. We're able to, because we preserve anatomical structures like the ligaments, we can rely on ligamentotaxis to load share on the graft and again stimulate bony healing and fusion. And the other advantages too we saw over the years is that with lateral interbody approach, we're really good at correcting deformity, particularly coronal deformity, where we're able to approach either side of the curve depending upon the clinical condition and needs of the patient, and really have a very powerful tool. And you can see here, very powerful tool from the lateral approach to correct coronal deformity. But what we noticed over the years and looking at it objectively, that while we were really good at correcting coronal deformity, we had mild and modest ability in terms of sagittal correction, with the exception of performing anterior ALL release or an ACR. And this is an example here where when we release the ALL, we really can correct the sagittal plane very, very powerfully, but it does come at some risk. And in general, the lateral approach, absent releasing the ALL, doesn't do a great job on the sagittal plane. It's more of a distracting procedure. It does separate the vertebral bodies, increase the intral disc height very powerfully with very mild and moderate sagittal correction. And so with all these advantages that we talk about with the lateral procedure, why isn't it widely adopted? It turns out only about 20% of spine surgeons actually use lateral transpsoas approach as part of their sort of surgical tools they have to treat their patients. And there's several reasons. One is this, there are opportunities to improve, of course, is the neural complications, and they're well documented, even with advances in the neuromonitoring that we talked about earlier that really validated the procedure as being safe. You can see here, there's not an insignificant number of neurologic events, most of which are temporary, but it is quite disabling and troublesome for the patient and troublesome for the surgeon having a patient with quad weakness or iliopsoas weakness after surgery. The other I think, barrier for surgeons is that there's idea of relying on indirect decompression. Now, a lot of work's been done on this, and it is a valid strategy is by using the inner body implant to decompress the central and peripheral nerve structures. There is still some instances in which we're not able to achieve that, and then requires the patient to have a direct decompression. And over the years with experience and some of the work with Juan Uribe, we were able to be more predictive of who we can take advantage of in terms of using indirect decompression and who will need a direct decompression, but it still has created a barrier for most surgeons to adopt this procedure. And then the reality is putting patients in the lateral position is a hassle. It does require a team, a group of people, and time. And then anything you want to do posteriorly in general requires the patient to be flipped prone. And when you add up the time to put patients in the lateral position and then flip them to do anything posteriorly in the prone position, surgeons are obviously time sensitive in their workflow. It just creates an aversion to adopt the procedure. The other thing you will see too in the literature and gaining popularity, both in our peer-reviewed literature and in our social media world, is this single position surgery. And largely when people talk about that, they're talking about patients in the lateral position, either going transpsoas or antipsoas, and trying to do the posterior work, if you will, whether it's putting implants in or doing decompression, all in the lateral position. Now this, and I can tell you from experience, is very difficult to do. Placing pedicle screws percutaneously or open using navigation, fluoro, or robotics is extremely difficult, technically challenging to do, particularly with the downside pedicles. And the literature is showing that the misplaced, the rate of reoperation and misplaced screws is much higher. Trying to do this single position surgery because of the technical demands and difficulty that are created in this position. We're also limited in what we can do. We can only do small, maybe 1 or 2 level constructs, doing single position surgery in the lateral position. And so obviously that limits the patients we can treat and what we're able to do. And then frankly, doing any bone work, osteotomies, decompressions in the lateral position, for me, is impossible. It's very technically challenging and really not something that I certainly would advocate or train any of my trainees to do. And so the solution to this was a procedure that we began to develop maybe 3 or 4 years ago, and then has rapidly started to gain popularity here in the States, and that's called the prone transpsoas approach. And I alluded earlier that this is a distinct procedure from a lateral prone surgery. You'll see these words kind of bounced around, and we want to be clear that when we talk about PTP or prone transpsoas approach, it's a distinct procedure in and of itself, and we'll talk about that later on in the talk. But what it does is it creates immediate workflow efficiencies. We're really doing, this is real single position surgery. The patient's in the prone position. We have access to all the prone anatomical structures to do whatever it is we want. It doesn't require a flip. It's a very straightforward positioning technique when we put patients in the prone position every day. And so as spine surgeons, we're very comfortable putting the position. It's very patient in that position. It's very efficient to do. It's comfortable in terms of in how we work. We work in the prone position on patients. And then it also allows us the advantages of all the lateral inner body, what the lateral inner body approach can give us that we talked about earlier. We can do minimally invasive operations. We could use big implants. We have access to the anterior column as well as the posterior column, and then we can have direct access, whether it be to decompression or osteotomies, to do posterior column work, as well as do anything at L5-S1. We will all do L5-S1 interbody fusions or decompressions. We can gain access to that, which becomes impossible in a single position lateral approach. The other thing, in which I think we'll talk about later, show you illustrated later, is that in the position, this is a very lordosing, sagittally, very lordosing procedure, in the sense that the positioning it creates lordosis. And so the earlier limitations we talked about in the lateral transpsoas approach, in regards to sagittal plane, the prone transpsoas approach overcomes them, and it's a very sagittally beneficial approach in restoring alignment for our patients. The way it's done is we use a standard Jackson table, and we put these, and we've developed these over time, these novel bolsters, we call them, positional bolsters. And what that allows us to do is to allow the abdomen to hang free, and really creates a very lordotic posture for the patient on the table. And we'll illustrate this later, showing you how well we're able to realign the spine in the sagittal plane because of this. And these lateral bolsters actually move in the coronal plane. And so that we can not only correct deformity, we're able to move the crest down, particularly for L4-5, so that we can gain access easier to those levels. And as I stated before, we have complete access to the dorsal columns, if you will, or the posterior columns of the spine, all the way down to the sacrum. So we can do what we need to do posteriorly, all in one position. We talked about the coronal, the bolsters, the novel bolsters, and this is why this procedure, PTP, is very different than prone lateral procedures that you'll talk about. It's not, and one of the things is this bolster that's been designed specifically to the procedure. You'll also notice, unlike some prone lateral procedures that illustrated, there's no taping. The patient's secured in the bolsters with the strap. And the bolsters are able to move coronally as well. And here we're able to gain access to this disc space by rotating the pelvic bolsters down to allow the iliac crest to be moved to gain very parallel access to the disc space that otherwise would have been more challenging. And then additionally, when we identify our disc space, we start to mark out some anatomical landmarks that are very different than lateral prone or lateral transpsoas. We want the approach to the spine to be somewhat more posterior, so we'll line up our posterior foraminal line and an anterior foraminal line, a mid-disc and an anterior vertebral body line, and approach the spine more posteriorly and then dock more anteriorly. Remember, we're dealing with gravity, and we've developed, and we'll show this later, a specific retractor for this procedure, so that we're able to reproducibly and safely approach the spine in this approach, and gain access to the anterior column and disc space. And so once we line up everything and get our orthogonal AP and lateral fluoroscopies, the approach is very similar. It's a retroperitoneal approach that's been well described in the lateral transpsoas. We gain access to the retroperitoneal space, start to put our dilators down, as you see here, gaining access to the retroperitoneal space, putting our dilators through the psoas muscle, and then stimulating or using the neuromonitoring to make sure that our approach and our docking location is safe in regards to where the lumbar plexuses. And once we get to the disc space, you can see here, it's very similar to lateral transpsoas in the regards that we have a guide wire. Our retractor goes over the dilators and guide wire. We open the retractor, place a shim to allow us to have a stable retractor. You'll see here, this is an older version where we have screw shims in the vertebral body. We've removed this, and I'll show you later what we've replaced this with, a very novel retractor system. But the thing to keep in mind is the basic tenets of lateral surgery stay the same, in that we want to stay orthogonal to the disc space so that we're able to safely prepare the disc space for placement of our interbody graft. The other, and not to be understated, advantage is the ergonomics of this for the surgeon. Those of us who do a lot of lateral transpsoas surgery know that at the end of the day, our upper thoracic neck, our back really is quite sore because we're leaning over the back of the patient to look down the retractor. Here we have a much more ergonomic workflow, if you will, and where you have the surgeon, this is a surgeon sitting, and he's able to look directly down the retractor into across the disc space. Or, and this is my workflow, I'm a shorter person, so I like to stand, and I just rotate the bed away from me, and I can look right down the retractor blade. And it's actually very easy for assistants or trainees to work with you, or you to watch what they're doing, because you can look just over their shoulder, as you see here, unlike with lateral transpsoas where you have to take turns looking in. The other advantage I want to point out in this picture here, here's one of the surgical residents. As we're doing the interbody, they're opening the posterior. So you develop a very efficient workflow. You're getting exposure to your posterior, to do your posterior work, whether it's osteotomies, decompressions, fixation, and while you're completing your anterior column work. And then the disc prep stuff, disc prep part of the procedure is all the same in terms of principles. We want to preserve the apophyseal ring. We want to create an optimal environment for the bony fusion. And then we want to create a channel for our implant to go in safely. And, you know, there's a variety of PEEK, or now we're using lots of metal in the disc space that are advantageous to create bony healing. And then closing of the wound is the same as it was for lateral transpsoas. So there's a lot of similarities, but there are distinct differences, not only in the prone transpsoas, but the PTP and lateral prone. There's very distinct differences that we just illustrated here. The other advantage too is we're seeing is that in the prone position, the lumbar plexus, this is an MRI study that we did. And basically what it shows is with the leg, with the hip extended and the legs in neutral position, the psoas muscle actually migrates posteriorly with the lumbar plexus. And this gives us the advantage of that we have more access to the disc space remote from the lumbar plexus, primarily the femoral nerve, making it, I think, giving us our ability to put larger implants in, and making it safer in that the lumbar plexus is more posterior, particularly with our ability to dock more anterior. We're able to get the safe access to the disc space more reliably. And then we'll talk about later, that segues into what makes the procedure, I think, safer, is that we have a novel integrated monitoring platform called SafeOp. Now, traditionally, when we did lateral transpsoas or XLIF procedure, we were only able to monitor trigger EMG. So basically, as we approached the disc space, we located the nerve by creating a trigger and monitoring the EMG function, and it would give us proximity of the nerve to the retractor and location of the nerve posterior to the retractor. And then we would go with our dilators and our retractor and then proceed with the procedure. But the thing to keep in mind is that the rest of the procedure remained unmonitored. We didn't know how well we were doing in terms of nerve integrity and nerve health and nerve continuity even, because the rest of the procedure, we didn't have the ability to get that information. And the SafeOp procedure, which is integrated in the platform of PTP, allows for this. And there's been lots of attempts for this over the years, but they've all failed. And what SafeOp does is it actually gives us saphenous nerve SSEPs, which, as you know, the saphenous nerve is a terminal branch of the femoral nerve, which at L4-5 particularly is what we want to monitor. There have been other attempts primarily with the posterior tibial nerve, but this is very difficult, if not impossible, and frankly is not the nerve necessarily we're most interested in. We're interested in the femoral nerve. So to be able to get SSEP waveforms of the saphenous nerve being the terminal branch of the femoral nerve, that gives us real-time nerve integrity information as we're doing the procedure. So if you think about it, we can, in the past, we would be able to locate the nerve and then not really know what we're doing to the nerve during the procedure. Patients would wake up with deficits, some of them temporary, most of them temporary, some of them permanent. But now with this new integrated nerve monitoring platform called SafeOp into the PTP procedure, we're able to get real-time nerve integrity, nerve health information, so we can make adjustments during the procedure if we start to see changes. And this is a perfect example of how this becomes an advantage for us. This is a case where we started. We had really good what we call triggers. The nerve was posterior to the blade. The triggers were high, so we didn't have the proximity to the posterior blade wasn't a concern, and we had really good waveforms on the SSEP of the saphenous nerve. And about 20 minutes into the procedure, we started to lose amplitude, and this alerted us to make a change. And typically what we'll do as an initial move is we'll just close the retractor for a little while to let the nerve recover. Typically this is an ischemic issue on the femoral nerve. Let it recover, and then continue along the procedure. And this we've seen, our ability to avert nerve injury because of this, because we're getting real-time nerve integrity and nerve health information. And so all of these factors, if you will, are created to do the PTP procedure very reliably and safely, and it's been validated over 1,000 cases now that we've done. And I again want to stress to you, the procedure is unique in and of itself. This is not a repurposed lateral procedure. This is a procedure that's been thought of to overcome the challenges specific to the prone lateral approach, or the prone transpsoas approach, so that we can, as surgeons, do this more safely and frankly more effectively in regards to what we need to do for our patients. And I'll illustrate that with a few cases. This is a patient, a 72-year-old, who underwent a previous L4 to S1 fusion, came back 8 years later with progressive disability from back and leg pain, failed a long course of physical therapy, non-operative treatment, including physical therapy and injections. MRI showed adjacent segment breakdown here, stenosis at the L3-4 level. You can see it on the axial circumferential stenosis. His standing X-rays show a lumbar pelvic mismatch of almost 30 degrees with a segmental kyphosis of about 10 degrees. And you can see the PIL mismatch here at 28, and just he has flat back deformity. He's got deformity in the sagittal alignment. His SVA is 14. So he's got sagittal deformity. He's got instability, a grade 1 spondylolisthesis at L5-S1, and he's been previously operated on at L4 to 1. So, there's any number of ways to do this, but a lateral transpsoas would not be able to accomplish correction in the sagittal plane, correction of the kyphosis, correction of the lordosis to get a better spinal pelvic matching. And so we opted to do a PTP operation. Here, the patient's positioned in the bolsters we talked about. In the bolsters, this is the preoperative X-ray at L3-4 was the operative level. We had a 10-degree kyphosis. In the bolster alone, because of the uniqueness of it, we're able to already correct the kyphosis and you start to see restoration of the lumbar lordosis. And this is before any work was done, any anterior column work, any posterior column work. And it just shows the power of the positioner and the patient bolsters, what we're able to accomplish just on the bed itself. And then we went ahead and we we chose to do the lateral interbody first. And here you'll see this is the newest and novel retractor specifically designed. It's a 2-blade retractor, very lightweight, with a very rigid, what we call A-frame retractor holder. Again, because we're dealing with gravity as opposed to, direct anterior or direct lateral, where the patient's, the gravity actually has the retractor leaned up against the patient. Here we need to adjust for that, and this is why lateral retractors repurposed for the prone transpsoas that don't work well. We've seen that, and we specifically designed this retractor for the procedure. It gives us the ability to view the disc space as you see here, and this is just where the retractor is first going down in a way, in a less invasive way, so that we can then do our interbody work or anterior column work. Here again, this is just some intraoperative X-rays. The disc prep, there you see the retractor. The disc prep is the same, and then the final AP and lateral X-ray that we get in the operating room when we're completing the prone approach. And this again is before any of the posterior work is done. And remember, he has circumferential stenosis, and we do need, because of the instability here, he would benefit from posterior fixation. So we can go right ahead. Here you see this is intraoperative X-ray. We can go and marry into his prior construct, add pedicle screws at 3, and accomplish everything in one position. Correct the coronal correct the coronal, sagittal, correct the nerve, the nerve compression, and add fixation all in one position. And here is preoperative standing X-ray with a PILL mismatch of 29 degrees. And here now we got the 20-degree correction and corrected the spinal pelvic mismatch by increasing his lordosis. And we see this regularly now without doing any anterior column release or ALL release. We're getting 15, 18, 20 degrees correction just in the position itself, doing standard disc prep and implant placement. I'll just go over, and here, this is the standing films, and this is the preoperative SVA, it was 14, and postoperatively, we got him back to 5, which is in the normal range. I know we're getting short on time. I'll just go through one other, and here you see this, the correction, there's a 20-degree correction from 10-degree kyphosis to 10-degree lordosis. I'll just show you one quick, this is a 60-year-old who had prior surgery, back and leg pain. They had a erosion of the upper screws into the 3-4 disc space. You see almost 20-degree spinal pelvic mismatch, prior surgery posteriorly, as well as a coronal deformity. This is the CT scan. You can see the operative level, the 3-4 eroded from the prior screws. There's a non-union at L4-5. And we're able to approach this. This is some intraoperative filming, get our incisions mapped out. And then we're able to, these are postoperative X-rays, able to correct the deformity, place implant in the anterior column, supplement the fixation, revise the old fixation, all in one position. And again, the advantage again in the sagittal plane, the lordosing ability of this procedure is evident. We're able to bring the patient back to normal spinal pelvic matching parameters. I think I was supposed to stop at 9:30, so I'm going to stop here and see if anybody has any questions. I know I covered a lot of information quickly.
Thank you so much, John. It is very interesting lecture highlighting the importance of using one position for finishing the procedure. There are 3 questions we have here. Can you do this procedure navigated?
Yes, so that's a great question. We can, and we use either 3D navigation and are in the process of validating 2D navigation that would just be used off the fluoro. So the short answer to the question is you can, and we do, and it can be very helpful. We even have done cases where we would do the posterior fixation robotically. So you can add that to the procedure. And the reality is you have the spine surrounded. And so anything you do normally posteriorly or laterally, you can accomplish with PTP.
Okay, John, regarding the patient positioning, you put the patient prone with hip extension. That means the psoas is tight and the neural structure inside the psoas is stretched as well. That may cause hazardous effect on the nerves.
I don't know where that question came from. That's a great question. And we've learned that with our experience. So when you do lateral transpsoas, we'll often break the bed in hopes of getting the crest out of the way. And so we took that principle with prone transpsoas using our patient positioning bolsters, and we would really coronally pull the pelvis down. What we were finding is before we even did anything, we were getting nerve changes. And so what we've learned is to not use, the bolsters are very powerful in the coronal plane. So we don't do much with the iliac crest. So the workaround then is, well, how do you get the crest out of the way? The reality is with the 2-blade retractor, we have about 10 more degrees of freedom. And so we're able to gain access to the L4-5 disc space without having to really pull down the iliac crest. But the observation by the questioner is absolutely right, is that the nerve is posterior, and we're finding that it sounds like it's seems to be under tension, and so not to be too aggressive with the coronal bender.
Okay, last question. In degenerative scoliosis, from which side you approach? Convex side, concave side? Especially, you said that you need to be in spatial parallel in your technique, parallel to the disc. So, degenerative scolio, so how you will approach?
Yes, in general, I approach it on the concavity. And if you draw parallel lines of each of the disc space, they'll converge to one area. So it allows us to make a smaller incision and still sort of wand up and down to the disc space to gain access and correct the coronal deformity. The exception to that can be at L4-5 if the pelvis is high and the disc is sort of looking or angling into the pelvis. I have to approach that on the opposite side. And so here is the other advantage with PTP is you can approach the spine on both sides. Unlike lateral transpsoas where you're committed to one side or the other, I can do some on the left and then some on the right.
Okay, great. So thank you so much. We have some more questions. You can answer them in the chat box because we need to go through the rest of the scheduled program. We're so happy having you between us. And the next speaker will be Professor Alan Levy. Professor Alan Levy will introduce his experience in intradural spine pathology. Professor Levy is a professor and the chair of neurosurgery in University of Miami Miller School of Medicine. John, can you stop sharing your screen? And Alan, can you share your screen?
Yes, let me.
Absolutely. I thank you so much for the invitation. It's a pleasure to spend a Saturday morning or evening with my colleagues from Egypt and my colleagues from the United States. I'm going to be speaking today about intradural spinal pathology. These are my disclosures. And just a little bit on philosophy before I actually start. You know, in different countries, it's different, but certainly in the US, you know, 65 to 70% of neurosurgical operations performed are spine surgeries. It is always interesting when I discuss with my colleagues in cranial neurosurgery about eloquence and comparing eloquence in the brain versus eloquence in the spinal cord. The picture to the left shows obvious eloquent areas of the brain, and this is a cross section of the spinal cord with the sensory tracts on the left and the motor tracts on the right. So, you can overlap those two halves, and you can very easily see that there is no non-eloquent areas in the spinal cord. Everything in the spinal cord is eloquent. And I would make the argument that when you're doing spinal cord surgery and you injure a single axon, that the patient suffers from it. While in the brain, there are certainly areas where you go transcortical and there are no untoward effects. The other thing I just wanted to mention is, the medical legal climate. Again, in different countries, it's different. I think all of us have this issue to deal with, but I mean, this is an interesting paper from England showing that even though cranial surgery outnumbers spine surgery by 2 to 1, the vast majority of lawsuits are related to spine. And if you dive into what are the reasons for these lawsuits, a lot of them have to do with faulty surgical technique. And I would say that the same is true in the US. This is a single center published article on medical legal aspects of spine care. But you can see that spine surgery far outweighs cranial surgery in terms of source of lawsuits. So I became interested in, intradural spinal pathology, early on in my residency and my fellowship. But I got to say that these are uncommon cases. When I look at my experience as a resident and fellow, I mean, I probably was involved in less than 30 cases total. And it's something that I've tried to focus on during my career. And I'll talk a little bit about a vast sort of range of intradural pathology, including extramedullary tumors and vascular malformations, as well as intradural intramedullary tumors. And so this is just kind of a summary over the period of 23 years of the distribution of intradural extramedullary versus intradural intramedullary pathology, and just sort of contrasting that during my training. And when I focus on intradural intramedullary, rather than talking about a very straightforward posteriorly located tumor, I was going to talk a little bit about ventrolateral pathology, which is really kind of the vexing part of these cases. So this is an example of a ventral meningioma at C1. I have discussions with my colleagues as to, is it better to go through a posterior laminectomy approach, or would they say, especially for a lesion that's slightly higher, is it better to do a far lateral approach? This is just showing a standard laminectomy with a paramedian incision, drilling a little bit of the facet, but not all of the facet, to create instability, and accessing this through a lateral dural incision. This is an example of a schwannoma that is also ventrolateral, but in a way where we felt like this would be very difficult to remove through a straight lateral or posterolateral approach. So this was an example where we used a true lateral approach, and navigation being very helpful to sort of dock on the lateral facet, drill the lateral facet, work dorsal to the vertebral artery, opening the dura and resecting this tumor. This is an example to show two things. One of which is some of the problems that you can get into with straight ventral approaches to intradural pathology. So this was a tumor that presented in another country where it was, you can see a very midline intradural extramedullary lesion. And these were MRIs done 10 years ago, and he presented with myelopathy. And the choice here was to do a corpectomy and access this lesion ventrally. Unfortunately, the patient, had an untoward outcome. He developed quadriparesis after surgery. And then one of the other big problems is, how do you deal with the dura? So he made a good recovery. We saw him 8 to 9 years later with deteriorating spinal cord function, as shown here on his neurological exam. And you can see this is a MRI from 2 years before we saw him, and he's suffering from an incomplete dural closure from that ventral surgery. And you can see that the spinal cord is being herniated through that ventral defect. And then when we finally saw him before surgery, you can see that that's gone on even more. And he's becoming progressively myelopathic. We had a lot of discussion about, what is the best approach? Is it better to go anterior? Is it better to go posterior? And this is the CT scan showing that the patient's fused. And we decided to go posterior in this particular case. You can see sectioning of the dentate ligament. You can see a small amount of residual tumor seen laterally, and you can see untethering the ventral cord through this video. And then you can see the herniated cord coming out through the ventral defect. And then ultimately, once it was reduced, we placed a graft ventral to the cord and sutured it in place. And this is a post-op MRI scan. Everything went well neurologically. Unfortunately, he developed a post-laminectomy kyphosis at the levels below where the surgery was done, and ultimately needed anterior-posterior reconstruction. We've developed transdural approaches for ventral lesions at the cranial cervical junction. And this is an example of using a more standardized approach as opposed to transoral or endoscopic approach to ventral tectorial cysts. And this is an offshoot of initial work that was done by Arnold Menezes in the mid-90s, describing the pathology of CPPD. A part of the push to do this type of procedure was noting that even though we have very skilled surgeons in our institution, that the complication rate, even from the transnasal endoscopic approach, can be high. And it's using a transdural approach for cystic ventral lesions that are eccentric. And this is an example of that. This is a patient with a ventral eccentric cystic lesion, and the transdural approach is basically opening the dura posteriorly, identifying the cyst, and sectioning the ventral dura to drain the cyst. So this is an example of an 81-year-old male who presents with neck pain and myelopathy. You can see this large ventral eccentric to the right cystic lesion compressing the cord, and he had this transdural approach to resect the cyst. This is another example, and most of these patients are elderly, so doing a very straightforward dorsal approach can take away some of the morbidity of the ventral approaches. So this is just showing a short video of that procedure. You can see the wide dural opening. Because the spinal cord is relatively small in this area of the intradural space, you can see you can access these lesions without any spinal cord compression. And then you can bipolar the ventral dura, and there's really no need to try to close the ventral dura. We just basically leave it open and close the dorsal dura. And then you can go underneath the cord and push any remnants in. Again, pre and post-op imaging. And sometimes the cystic contents are different between the two. That was a cystic one. This is more of a, I would say, like a gooey one, if you will. And then again, we've published this procedure, some needing fusion if they have pre-existing occipital cervical pathology. And again, pretty low morbidity in patients who have high morbidity outlook, being elderly. And so the last part of the talk, I'll just talk about intramedullary tumors, and not about phylum Terminale myxopapillary ependymomas, but true intramedullary tumors. You can see the age range here. Interestingly, when you look at least my series, that in the adult, the ependymomas outnumber the astrocytomas by more than 4 to 1. That's not true in the pediatric population, and there were quite a few hemangioblastomas as part of it. And then a bunch of different miscellaneous rare tumors as well. I think one of the critical things, and I'll talk about this at the very end, is that these intramedullary tumors always present with a protracted history, unless they have hemorrhage. But it would be very uncommon to see someone with an intramedullary lesion having symptoms for only a week. And I think that's an important distinction in working these patients up. And we're going to talk about some mimickers of intramedullary process that might look like tumors, but are in fact not tumors. And these are the locations of these lesions. Most of them are cervical. And then, trying to figure out what they are, knowing if there's a syrinx or no syrinx is important in trying to figure out if they're ependymomas or hemangioblastomas. And we'll go over some case examples. When we do these surgeries, they're obviously prone. We don't use paralyzing agents, so we can do SSEPs and MEPs. We occasionally give cooling or steroids, prophylactic antibiotics, and maintaining the MAPS at 80 to 85 during the surgery. These are some important surgical adjuncts that we use: ultrasound, microscope, cavitron, and laser is really only helpful for lipomas. Again, neurophysiological monitoring we feel is important in these cases. And there have been techniques described to find the midline dorsal raphe. I personally don't use them, but it can be useful if a cord is very rotated in terms of finding the midline. I think the most important thing is this finding the midline in the dorsal columns, because this really determines what the patient's postoperative dorsal column dysfunction and complaints might be. So this is a typical example. You're looking at the dorsal cord. You see this wandering midline dorsal vein, which is really never in the exact midline. But this vein often gives tributaries that dive into the midline raphe. And so if you can find where those veins dive in, that's the best way to figure out where the actual non-axonal midline of the cord is. So for techniques, we usually try to achieve gross total resection. Duroplasties is needed, lumbar drains is needed. And so we'll go over a spinal cord ependymomas to start with. These usually have fairly distinct gliotic margins, but not always. We try to get a complete resection. If we can't, for some reason, I prefer not to radiate these tumors because they are slow growing. This is an example of a young woman with an ependymoma and a large cyst. Obviously, we're just focusing on the tumor removal when we're doing the surgery, and the cyst, once the tumor is removed, will come down on its own. This is showing removal of the tumor after the midline myelotomy. This was a case that I saw, was a firefighter, young man who, we talked about doing surgery in 2014. He was not excited about the potential dorsal column dysfunction and the impact that might have on his career, and saw another surgeon who recommended just radiation. So the patient had radiation without surgery, without a diagnostic tool of knowing exactly the pathology. You can see that there's some necrosis centrally of the tumor after the radiation. This was just external beam, but then the patient presented in 2016 with progressive quadriparesis, and then we ended up doing surgery. Again, surgery was much more difficult after radiation. You can see this splitting the raphe and seeing these diving veins going in towards the tumor. Astrocytomas, they're less common, and they are more difficult to treat. There's often not clear margins around these astrocytomas. If you're lucky enough to know that it's a GBM prior, you can consider a chordectomy in those patients. This is example of one who had a juvenile pilocytic astrocytoma. This is low grade and usually resectable with margins, but this is an example of a diffuse unresectable astrocytoma. And this would be more of a biopsy type duroplasty procedure, as shown here. Hemangioblastoma is, again, the second most common tumor in this series. The thing here is not to biopsy them. You can do embolization for the larger tumors, but often they do share a blood supply with the spinal cord. The cyst that's often present resolves with tumor excision. This is a case in von Hippel-Lindau disease with a intramedullary C2 lesion with a cyst, and you can see we did an angio. You can see the blush of the tumor, but our interventional people were not able to embolize it. And this is showing intraoperatively resection en bloc, not biopsying the tumor, and trying to delay the sacrifice of these large arterialized draining veins until the very end. This is an example of a ventrolateral sort of exophytic hemangioma. Bipolaring the capsule is super helpful. Without getting into it, it makes it more firm and reduces the blood supply. And this is post-resection. Cavernous angioma is uncommon, but we see them. And again, if they present with hemorrhage and deficit in a younger patient with a tumor that presents to the surface, that's definitely a surgical case. This was an 18-year-old male who presented with left-sided hemiparesis after a hemorrhage. They look the same as they do in the brain, and he underwent resection. This is the venous angioma associated with the lesion. This is after opening the dorsal root entry zone. You can see the mulberry bush appearance of the lesion, and then post-resection. And again, the emphasis here is trying to avoid post-operative dorsal column dysfunction. And this is the thing that is the most vexing, both to the surgeon and the patient, and really spending the time trying to find that midline dorsal raphe, I think, is critical. And obviously explaining to the patient what are the anticipated consequences of the surgery are the next most important. These are other potential complications of the surgery that need to be discussed with the patient. And then I'll just finish in the last 2 minutes, so there's lots of time for questions, is this problem of seeing patients in the clinic, and this is actually a favorite question of our oral board exam, is seeing patients who present with enhancing intramedullary lesions to the neurosurgeon that are not tumors. And there's lots of different examples. So this is a patient, a young woman who has had monocular blindness at one point in time, now presents with spinal cord dysfunction that's acute in onset and has a lesion that's in the cord that expands the cord, that has some enhancement. And this is a case of multiple sclerosis, and in particular Devick's disease that's limited to the spinal cord and optic nerve. Obviously, going in and biopsying this lesion is not the right thing to do, and taking a careful history and understanding that these patients have this acute presentation, not the chronic presentation that most of the tumors do. This is another example of cervical stenosis with myelomalacia. And if the referring physician happens to do a GATTED image, you can see enhancement of this lesion, which can look like a tumor because there can be focal enhancement. Usually there's atrophy of the cord as opposed to expansion of the cord. This is an example of transverse myelitis. And again, in a patient who had enhancement, there's focal enhancement. He's got progressive, relatively rapid quadriparesis. So you know that you do not want to go in and biopsy this lesion. And so that's all I had. I appreciate your time on a Saturday morning, at least in the US, and I'm happy to take any questions.
Thank you so much, Alan, for your presentation. It was really conclusive with a lot of tips and tricks. We have from the participants here 3 questions. Is there any tips and tricks for neurofibromatosis, especially?
You know, these are patients that are very challenging. Obviously, they often present with neurofibromas in the spine and outside the spine. You know, I would say in general, when you're removing intradural extramedullary tumors, schwannomas, neurofibromas, meningiomas, in general, you do not have to do a fusion. You know, you can just do a simple laminectomy in the vast majority of cases. Now, there are exceptions. You know, sometimes if you have to remove a lot of the facet joint, if you are crossing cervical thoracic or thoracolumbar junction, sometimes it's appropriate to fuse, but the vast majority are not candidates for fusion. We did a study looking at this, and I think 16% of the patients in our series ended up with a fusion, but most of those patients who ended up with a fusion were patients with neurofibromatosis. And again, it has to do with the complexity of their tumor, the fact that they're often dumbbell shaped, the fact that you're often taking a lot of facets, and they probably have a propensity for instability after surgery. So that's the one thing I would say about neurofibromatosis patients.
Regarding if we have intramedullary tumors with the spinal deformity, how you will approach that?
That's not that common, intradural with intramedullary pathology with scoliosis. So I mean, I would say that we would do the surgery for the intramedullary tumor to start with, and if necessary, address the deformity at a secondary surgery. I can tell you, I'm not a big fan of doing intradural surgery and instrumentation at the same time because of the cavity or the post-op cavity that develops from placing the instrumentation. So if I often will say, you know, let's do this, and if we need to, we'll do the instrumentation secondarily.
Okay.
Alan, can I ask a question, Alan?
Yes, yes, sure. We are happy to have Professor Atul Goel between us. He is one of our panelists, and he is a great mentor for all of us. Professor Goel.
Good morning, Dr. Goel.
Please.
Thank you. Good morning, Alan. That was a great presentation. And needless to say that whatever tips and tricks you have presented will be very useful. Only one issue I would like to discuss with you and probably question you. You see this retroodontoid cyst that you are mentioning and retroodontoid calcification you are mentioning. I wish, you know, if you have read my articles on the subject, which are several articles since for about 20 years. And we have mentioned that these retroodontoid cysts and retroodontoid pseudotumors and calcifications are manifestation. They are not primary, they are secondary, and they are manifestation of atlantoaxial instability. And you do atlantoaxial stabilization, they disappear, you know, spontaneously. As you rightly mentioned that these are associated with degenerative changes of the spine at multiple levels. So in one of my articles, I mentioned that like osteophytes, retroodontoid cysts are like osteophytes. Like osteophytes are indicators or secondary to instability of a spinal segment. Similarly, retroodontoid tissue of all kinds, including the cyst and that gooey kind of thing that you were showing, are all manifestations secondary to instability, and only stabilization is the treatment. What do you have to say about that, Alan?
Yeah, I would say that none of these patients had calcified lesions. I would say that these are sort of tectorial membrane cysts that are asymmetric. that some of the patients who had instability had fusion in addition to removing the cyst, but not all of them. I would say about 50% had fusion and 50% had not. And, you know, we've been doing it since 2015. And so we're like 6 years post. These are very elderly patients. And we haven't seen any recurrence. We've had one complication, which was a CSF leak that needed revision and repair. So I think that would be my response, is that not everybody needs a fusion. Clearly, if there were patients who had imaging that showed instability or incipient instability, those patients ended up getting fusion. But if there was only a cyst and no evidence of instability on imaging, they didn't get a fusion, and they seem to be okay in at least the 6-year follow-up that we've done.
I will, even then, Alan, I will recommend that you please go through some of my articles, and
Absolutely.
I hope you will get some, you know, some more insights into this very intriguing pathology in this region.
Absolutely,
Which
Dr.
people
Doyle.
have been
For your-
including, you know,
for your
people
comments.
have been removing this with endoscope, by lateral routes, by posterior routes, by anterior routes. So many routes have been described to remove this. You know, essentially, they are very easy to remove. You puncture the cyst and you remove the cyst. Question is, and a little different way of thinking is whether you can avoid that. So that is the thing that I wish that you read this in a few of my articles, multiple of my articles, Alan.
Absolutely, Atul. Thank you for your comments.
Thank you, Alan.
Thank you so much, Dr. Atul, for your comments, and thank you, Alan. There are only one question left, and the rest you can answer it directly to everyone, please, Alan. The last question is how to kindly elaborate the landmarks to find the midline raphe.
I mean, yeah, I think that as that picture showed, you know, there's the midline dorsal vein that is a sort of guide to the general area of where it is. Another guide is looking at the dorsal root entry zone and looking at the halfway point, but ultimately it's high magnification on the microscope and finding where these tiny little veins come off the midline vein and then dive into the spinal cord. And then when you open the pia in that area, you're able to see that natural separation. And so that's sort of the guidelines for finding that midline dorsal raphe.
So thank you so much. So shall we go for the rest of the schedule? Sameh, kindly introduce our next speaker.
Okay, thank you, sir. And now we will represent Dr. John Shen, Associate Professor of Neurosurgery and Spine Surgery, Harvard Mass General Neurosurgery, Director and Spine Oncology Deformity Surgery. We are waiting for you, sir. Thank you.
Great, thank you everyone. And really thank you to our colleagues for inviting me to this great webinar. It's a real pleasure to be here and also to hear these great talks by my US colleagues as well. So I'm going to share my screen. Okay, can everyone see my screen okay?
Yes, it is okay. Please.
Great.
It's okay, sir.
Perfect. Well, no, so fantastic talks this morning. And I think my talk is going to focus on reconstruction and stabilization considerations for spine tumors. And this will be sort of expanding what I think Dr. Levy just really brilliantly discussed in the prior session on intradural pathology. My talk will specifically look at extradural pathology, mainly involving bone of the spinal column. And we'll share some insights, some considerations as we approach primarily metastatic and primary spinal column bony tumors. These are my disclosures. So we'll start with a couple cases just to set the context. This is a 49-year-old patient. This is a patient we typically see, whether it's in clinic or your emergency department or urgent care center. someone coming in with a lot of back pain, and the ER or the primary will get an MRI demonstrating this finding in the bone in the spinal canal. Here, this is at the T10 level. The patient has so much pain, they really can't stand or walk. Your resident will go see the patient and they're moving their legs 5 out of 5, and they say nothing urgent is needed. But when you look at the scans and you look at the axial imaging, you can see that there's significant epidural extension, retropulsion, slight pathological fracture of this vertebral body. And the question becomes, how do you treat this patient? What is the ideal treatment, whether surgery, radiation, combination of the two, other modalities? And when it comes to surgery, what's the approach? Anterior open thoracotomy, posterior intralesional resection, en bloc resection. There's so many ways to think about this, and I'm sure that many of you who are watching are also thinking in mind, oh, this is how I would do it, or there's no question, this is my approach. And so we all have our own biases and sort of decision making. Yeah. Making algorithms.
It's okay.
Here's another case of a patient with chest pain, came back as chordoma. And similarly, one would think, what is the proper treatment for this? How would we operate, reconstruct this? And there's another case of a patient with a chordoma in the lumbar spine at L4, neurologically intact, back pain, some slight left leg radicular pain. But the question becomes, how do we treat this? Surgically, reconstruction-wise, implants, materials, what's going to provide the best durability instrumentation point? So there are a number of challenges in spine oncology. I think Dr. Levy really showed sort of what we face as surgeons in the intradural space, whether intramedullary or extramedullary. But when it comes to cancer, small column tumors, clearly there is, because life expectancy is changing, especially with patients with metastatic disease, goals for different tumors, and there are so many interventions now. And we have to think about the goals here. Obviously, we want to preserve neurologic function, make better. We want to stabilize the spine, address some of the oncology principles of local tumor control, and ultimately, we want to help these patients with their pain and quality of life. But we need to balance the invasiveness of surgery with also the frailty of the patient and what that patient can withstand. So I'm going to start just talking about metastatic tumors, and this I think everyone knows, but I think it's just helpful to review that, for patients with metastases, I would argue that the goal really is palliation of pain. And it's not for cure, because we know these patients have systemic disease. And some may argue, in the context of solitary metastases, is there a role for en bloc resection? But I think in the age of adjuvant therapies and now targeted molecular therapies, I don't think we're seeing so much of that anymore. But obviously, we want to think about what is it that we do that's going to help set that patient up for durable local tumor control, adjuvant therapies. And again, it's weighing the invasiveness of our intervention and also the frailty or the sort of medical fitness of that patient for that intervention. Mark Bilski and colleagues at the Sloan Kettering have really proposed and championed this decision-making algorithm called GNOMES, which many of us use. And it's a very helpful algorithm and conceptual framework to think about the various components of these patients. And I'm not going to go into this in detail, but what I would say is that, we're all very good at assessing the neurological function of these patients. We have a good understanding of the radiosensitivity of cancers. And also now with instrumentation systems, technologies, better understanding of biomechanics, we can address stability in a number of ways. But we all have trouble with predicting survival, anticipating complications, and ultimately thinking, is it worth it for this patient? We published a paper recently in Neurosurgical Focus looking at the various frailty models and using our own MGH cohort of almost 500 patients over the years, and really trying to test out, one of these models and to see, how effective are these predictive models in helping us understand how frail a patient is. And, are these models that you're seeing published a lot in the literature, how applicable are they? And can they really be used as bedside decision-making tools? So in our own experience at the MGH, our overall complication rate after metastatic tumor surgery is about 30%. But what we found was that this frailty index performed rather poorly when we looked at our own data. And when we looked at postoperative complications as well as inpatient death afterwards, we noticed that there was certainly a trend as patients who were defined as more frail, as their frailty increased. But there are issues and considerations with how we are actually defining what frailty is. And that is still a moving target. And I think it's something that, whether it's in the US or abroad, we all have different ideas of what consists of frailty in that patient, whether it's their level of function, their level of their nutritional status, the degree of cancer, or even how healthy they are, whether they have medical comorbidities. So this paper, in our experience, really highlights how we really need to move the needle forward a little bit with regards to how we're thinking about risk stratifying these patients. Because again, we can think about, we were really good at assessing all these variables, but when it comes to frailty and potential complications, it's quite challenging. And we typically, as spine surgeons, consider surgical stabilization for deformity, pathological fracture. Sometimes these patients present to our hospital, transferred in with horrible pathological fracture and cord compression. And, we don't really have much choice. We're operating on these patients urgently to address not only the deformity, but also the instability and the cord compression. And sometimes not even knowing what we're dealing with, not even knowing what type of cancer they have. We also see that patients fracture and have significant pain after radiation. That can happen whether they're having conventional radiation or stereotactic radiosurgery. We also know that by doing a laminectomy alone, a dorsal approach, in weakened bone affected by metastases, that may also affect the structural integrity due to the decompression. We've seen evidence in the last talk of post-laminectomy kyphosis after intradural surgery. That can certainly happen in bony spinal tumors as well. And we also have to be mindful of the clinical history. We have tools like the SIN score, which I know everyone is familiar with. And also, we have great biomechanical concepts and data. This is from Dr. Benzel's textbook, demonstrating that ultimately over time, we shoot for fusion. But we know that in certain cases, especially metastatic disease, these patients don't have that timeline. So we have to be very mindful about how we're reconstructing those patients. So we can put all that together and come up with decision-making algorithms. And again, surgery is not easy, right? In the United States, there's been a lot of data published on readmission and complications after surgery. And if you have metastatic disease, the last thing you want is a complication, because that's going to delay your treatment for other medical or radiation type therapies. So we do our best as spine surgeons. Again, we're all pretty bad at predicting the future, but we do our best. And we do our best to reconstruct, stabilize the spinal column. But failure can happen. And I'm sure many of you have experienced this, and I'm all have nothing to hide. I certainly have my own failures as well. And whether it's rod fracture, kyphosis, or subsidence of cages or reconstructions, it does happen. And we want to try to avoid that. So there are a lot of emerging technologies, and one of the technologies specific to spine tumor surgery that I've been using over the last several years is fenestrated pedicle screws with cement augmentation. And we recently published our series looking at this in treating patients with tumor-related spinal instability. And we found that, in the thoracolumbar spine, I inserted nearly 500 screws over the last several years, and the rate of cement extravasation was about 30%. Interestingly, most of these were really not clinically consequential, and most commonly were through the segmental veins. And I think if you look at this figure, we tried to characterize a number of the different type of extravasation patterns that we saw. So when you look at figure A, that's typically what we all want, right? You can see the cement clustered around the distal tips of the screws within the vertebral body, clearly away from the aorta, nothing in the canal. But then we see different patterns. We see in caption B, you can see it in the segmental vessels laterally, and this is where we see it most often. Now, interestingly enough, you can see that the screw has not transgressed any cortical aspect, whether it's the pedicle or vertebral body, but just because of either the viscosity of the cement, the bone quality, you're seeing it extravasate. And we see that in a number of different examples here. And you can see medialized screw, you see some cement in the canal, you see, cement that can follow the basivertebral vein into the canal as well. So, we found that the screws are very effective, but we do see extravasation most of the time inconsequential. But when we looked at their pain scores, we did this prospectively looking at various pain reported outcomes. And there's clearly a benefit, not to say that it's because of the cement itself, but with the rigid instrumentation. I think there's a lot of retrospective case series reports demonstrating that, yes, there is a role for instrumentation in metastatic cancer, but we're able here to quantify that using prospective pain scores. And we see that the pain intensity and the pain interference benefit for these patients is significant. And this is just an example, intraoperatively, what that looks like. This is just one of the systems on the market where you can see that these are the towers that are attached to the screws, and these are the cement delivery systems that can be done, whether open or MIS. And we can see the extent of cement fill using intraoperative fluoroscopy. And with navigation, there are ways to percutaneously put in the screws. And it's interesting to see, with robotics and different technologies now, how can we can continue to push this forward, minimizing the morbidity. And this is one case example how a patient had previously underwent a staged anterior and posterior operation many years ago, then presented with further collapse, distal junctional kyphosis, inability to stand upright, disease progression at the bottom part of their construct, no neurological compromise, but a true functional deformity. And was able to revise using these fenestrated screws, and she did fine until her eventual death from systemic cancer. But this helped limit the need to fixate and extend to the pelvis in a patient with metastatic disease. Here's a case of a patient pretty sick, but this just shows how robust instrumentation can be for these patients. This is a patient with metastatic lung cancer with EGFR positive who had previous extensive radiation, not only to the spine, but also to the chest wall for a lung lesion. And this patient had progression in many areas and failed various therapies, but they're coming in with significant spinal cord compression. And one would ask, what is the role for surgery here? But this patient presented with significant acute neurologic decline. And oftentimes it's difficult and challenging to have a goals of care type discussion in the urgent, emergent acute setting. And this patient was expected to live approximately 6 months. And you can see the extent of epidural spinal cord compression, high grade compression in a very challenging area at the cervical thoracic junction. So using these tools, this is unstable spine. This patient underwent a posterior operation, what we call separation surgery, where the pedicles are drilled down into the vertebral body, intralesional resection, partial resection of the vertebral body, resection of that posterior vertebral body wall. I use a down-angled curette to really tamp down that retropulse portion. I cut the posterior longitudinal ligament to ensure that we've really established a ventral decompression as well. You can see the exiting nerve roots here, a wide decompression. And this is post-op imaging. You can see that clearly this has not been reconstructed, at least in my hands, taking the extra time and effort to try to reconstruct this with a cage or device, especially at the cervical thoracic junction, is quite challenging because of the window there. So the goal was really to restore this CSF signal ventral to the spinal cord. And you can see that on the CAT scan. You can see the extent of the intralesional resection there, with the goal being that we'd send this patient for high dose stereotactic radiosurgery to provide local tumor control. And this is just an example of the dosimetry plan demonstrating how that type of separation allows the radiation oncologist to really deliver very high dose radiation to that area. Here's a patient with metastatic prostate cancer, again, presenting with pathological fracture, severe cord compression, as you can see here, with profound neurological deficit within 24 hours. And you can see the extent of epidural compression, mostly ventral, related to that vertebral body disease. And you can see that the patient has other issues elsewhere. And that's really a hallmark for really the extent of disease. This patient, I used a carbon fiber system. This is not a titanium-based system, but this is a carbon fiber system. And this is the patient's prone. To the right of the screen is cranial. To the left of the screen is caudal. And you can see the fecal sac. I ligated the nerve root on the right side because it was densely involved and adherent to metastatic tumor. And you can see here the bilateral transpedicular drilling. Again, same approach, really getting into that vertebral body, resecting the posterior aspect, pushing the contents down with down-angled curettes, Woodson elevators to make sure that we have really circumferential decompression. And this is just one of the various systems available on the market, the carbon fiber that now that I've been using to try to help with the radiation planning. And this is post-operative, what we can see here. And they almost look invisible, but you can see the shadow of the screws. There's a thin titanium coating around that. And this is the AP and the lateral. This is a post-op CT. You can see what that looks like on the sagittal and the axial imaging. And again, at that level of that vertebrectomy, it's a partial intralesional resection, taking away and separating enough of that posterior vertebral body element to create enough room for the radiation oncologist. And this is why that's important. So conventional MRI, at least at our center, after titanium implants, this is what it looks like. And so for our radiation oncologists, it becomes very difficult to plan radiation because of that. And typically in our workflow, we obtain a CT myelogram. This is another case of a lady with metastatic breast cancer here with an L4 pathological fracture with severe back and left leg pain, cannot stand, cannot walk, neurologically relatively intact, but essentially bedbound because of the inability to stand due to this pain. We considered cement augmentation, but our interventionalists were wary of that because of what they thought was retropulsion and epidural extension, particularly into the left foramen. She was having some mechanical radiculopathy, pain going down the left leg with weight bearing. And so we put this to our SINS algorithm, questionable, unstable, intermediate. So in some situations, could you consider cement augmentation? Possibly. But then when I'm looking at the scans, thinking about open surgery after the radiologist sort of passed on their intervention, I'm looking at, we're thinking, are we doing a posterior operation, separation surgery, 2 levels above, 2 levels below? You may be inclined to think that way. Is that going to be less morbid for the patient? Then I look at the CT scans and I see that the pedicles are very small. So then I'm thinking, at least in my experience, I don't know how I would get a screw into that channel. I don't want to violate the canal or the foramen. And possibly now with robotics and augmented reality, maybe that is more accurate than other navigated freehand or fluoro-based techniques. But in this experience, I did this through a lateral, mini open, minimally invasive approach. But I think going back to the the approach that Dr. Polina showed before, is this a great case for the PTP approach? And it might be. I have not personally done it that way, but I'm very intrigued by that because maybe from a prone approach, you can do the anterior column reconstruction and put in the screws as well using various technologies. So I think that's an interesting corridor and avenue. And this is what I essentially did. It's a mini open with a retroperitoneal exposure, anterior column reconstruction, followed by anterior instrumentation with augmentation. Now, in the last couple minutes, I'm going to switch gears, about 5-7 minutes. I'm going to talk about primary tumors. And we know that for primary tumors like chordomas, sarcomas, chondrosarcomas, the goals are different. Giant cell tumors. When we think about metastatic disease, we're thinking about intralesional resections, but here we're thinking about wide excisional resections. Just like this patient here, which I'll show, how are we going to reconstruct this involving multiple vertebral body levels? When we look at treatment approaches for chordomas around the world, depending on where you are in your institution, you may have a very specific recipe or algorithm. At the MGH, we have a very specific algorithm as well that employs preoperative radiation, high-dose protons, followed by en bloc resection, followed by adjuvant postoperative therapy. But as you can see on the slide, there are a number of different possible algorithms based on your institution, the resources, and the expertise provided. Well, what about an ideal reconstruction strategy? Is there one? This review performed by the AO Knowledge Forum showed that when you look at the literature, it's all over the map. So whether you're in Japan, Italy, the United States, multiple centers around the world, there may be a different type of reconstruction strategy. So when we think about these cases, we use the WB schematic to think about where we're going to make cuts into the bone. And this is just an example of our approach when we're doing spondylectomies. We're doing circumferential dissection around the vertebral bodies. We thread the Tomita wires across the vertebral bodies and the discs, and we eventually amputate that, and I'll show an example of that. And this is just that example. We perform dissection around the spinal column in the thoracic spine, bilateral rib resection, paraspinal dissection. We're floating the saws through these tubes around the vertebral column so that we can anchor around the disc space of the vertebral column. And the tube serves as a conduit that we can pass the thread wire saws. And when we come in on an approach the subsequent day, we can literally harvest or find the saws and make our amputation and osteotomy cut. And this is just what that shows. It goes around the column and it goes in front of the dura in the epidural space. And you can see that right here. I'm just holding back the lung here so you can see where those thread wire saws go onto the side. Okay, and this is just what that looks like. You have the chest wall here where the chordoma is involved. We have multiple nerve roots identified, the vertebral artery identified, and the saws anchored to the rods on that side. CT scan in between demonstrates the osteotomy cut above. We see where the saws are going to be at the level where we're going to come through on the next stage. You can see the extent of the saw going around the vertebral body, away from the aorta and the venous structures, and also the saw in front of the dura, the thecal sac as well. And this is just a video demonstrating on this particular case. This is our thoracic surgeon performing the sternotomy anterior approach to the upper thoracic spine. Again, sternotomy here. They're going to get us the window to get into that space. So that we can find the saws, use the handles to make our amputation through that area, okay? And this is just what that looks like. So we're retracting the lung, we've identified where the tumor is, and now with the saws and the handles, making our cut through the vertebral body area. And eventually, there are always soft tissue attachments that are there, ultimately making those soft tissue dissections and then resecting the specimen en bloc. And then we reconstruct this using a fibular graft with our other surgeon who is obtaining the fibula. This is the spinal cord that you can see here. We're going to perform the anterior column reconstruction using our vascularized fibula. That's obtained here. Fibula is being cut to size and being inserted for reconstruction, being tamped into place. And finally, this is what the reconstruction looks like with the anterior kick-out screw. Specimen, and this is our illustration diagram for what that looks like, and with a postoperative CT at more than 2 years. And this was recently highlighted in the JNS Spine, if anyone's interested in looking at that further. So in our experience, we do this approach for chordomas because in our center, we employ high-dose preoperative proton radiation therapy that, as you can expect, affects the bone quality. It also affects the soft tissues for wound coverage and recovery. The vascularity of the bone also is impacted, so the fusion rates with conventional cages is significantly inferior. And so in our experience, what was recently published, there are 39 patients, in this series of patients, our fusion rate is almost 80%. We've had subsidence, we've had some fibular graft fractures, particularly in lumbar cases, and we've modified our technique in the meantime to account for that. But in our experience, given the radiation treatment, this has been our strategy up front. So I thank everyone for, again, staying tuned to this talk. I hope it was informative. But basically, we have multiple options for decompression and stabilization. Clearly, there are emerging technologies. We heard about PTP before. I know that Nick Theodore is going to talk about robotics and show just how we're continually moving and evolving in our instrumentation strategies. And I think the key here is, we can go from MIS to maximally invasive, right? And so the question really ultimately becomes, how do we weigh the invasiveness of surgery with also the frailty, the goals and expectations for these patients? And also I'll make a plug that multidisciplinary collaboration is clearly essential. So thank you very much. And I hope this was informative for everyone. Thank you.
Thank you, Professor Shin, for this elegant lecture. I don't see any questions on chat. Just one question.
May I ask Dr. Sameh, Dr. John Shin, something regarding the screws? There is PEEK screws or carbon PEEK screws usually, or can you when to recommend using these carbon screws or non-metal screws in tumors, when to use it? And what is the role of carbon beam or proton beam radiation nowadays in tumor surgery?
So that's a great point. So typically, the carbon fiber screws I only use when we know for sure that, to the best of our ability, that patient is really going to have some type of high dose radiation therapy afterwards. Because that's really the benefit, is in reduction of the imaging artifact scatter on the imaging. So if I know that patient is going to have, a high dose radiation afterwards, and that it's not completely just a palliative case, then we'll try to use that technology. I think now, again, with your question regarding protons and carbon ion, I think that, there are many proton centers being established as well as carbon ion across the world. And I think that there is definitely a benefit, but a true comparative analysis is lacking, and that type of data just really doesn't exist. So that's why many of the reports really do fall upon local, institutional, regional sort of practices.
Okay, regarding sometimes you need to put cement inside the affected vertebrae, and it may lead to more spread of the tumor inside the body. So some colleagues advocate the use of radiofrequency ablation before injecting these vertebra with cement to create void. Do you believe in that?
Yeah, I think that's that's a great theoretical concern, but I think it's very difficult to demonstrate and prove, right? So I think that we're not at the stage yet where we can do, venous sampling, of tissue or even visualize that. I know that there's some thought in the intracranial aspect of, visualizing sort of the venous outflow of tumor cells and brain tumor resection. We're not quite there yet, I think, in the spine. So I think that is definitely something to think about. And I think from a research standpoint, worth evaluating. But right now, I think it's a theoretical concern, but very difficult to assess clinically.
Okay, Sam.
There is one question on chat. How comfortable are you prefixing these patients combined with a mini open aspiration surgery and completely bypassing an attempt at outsourcing given increased life expectancy with new chemotherapeutics immunotherapy modalities?
That's a great point. I think that, I think realistically, every cancer patient is different. And there's some patients that we know are not probably going to live more than 3-6 months. There are others that maybe are at the beginning of their cancer journey. And so the attempt to arthrodesis, I agree. I think we do it, but, I'm not harvesting iliac crest or doing anything like that. So I think we make our attempt to arthrodese, but knowingly that, these patients may not have the survival to benefit from that. So that's why I think trying to maximize the fixation and the properties of fixation upfront is very important.
Okay, I don't see any questions on chat. We open the panelist to question. If any panelist have any question, please be comfortable to ask it. Okay, thank you, sir, for your time, and thank you for accepting our invitation. And now we will shift to the next speaker. Next speaker is Professor Nader Dehdala, Associate Professor of Neurological Surgery, Director of Neurological Surgery Residency Training Program, Department of Neurological Surgery, Northwestern University, Feinberg School of Medicine.
Thank you so much for this introduction, and I'm really honored to be speaking this morning or this evening, depending where you are in the world, amongst my superstar colleagues and panelists. Let me share my screen. Let's take a peek here. And can you see my screen clearly?
Yes, Nader, it is clear.
Thank you so much. And again, thank you for including me this morning and this beautiful day of education. These are my conflict of interest, none of which are relevant to this talk. And this talk is really, and the CVJ is really dear to my heart as a pathology that we treat. And briefly, a review of anatomy here. When we're speaking about the CVJ, the cranial-cervical junction, upper cervical spine, or the occipito-cervical junction, we're talking about 2 joints, 3 bones, the occiput C1 and C2, and the atlantoaxial joint and atlanto-occipital joint as well. So these are the vertebrae that constitute C1 and C2. They're very unique in shape and anatomy. And let's not forget that the C2 joint has 5 synovial surfaces, and paying attention to the anterior one here, just in front of the odontoid, as this is a joint that can be also involved in inflammation and progression of rheumatoid arthritis. So the anatomy determines function. So the range of motion and the direction of motion is determined how the joints are oriented. The C1 occiput joint is cup-like in the coronal sagittal plane, allowing for flexion and extension with lateral axial rotation, while the C1-C2 joint, atlantoaxial joint, is convex in orientation allowing for axial rotation about the dents. What stabilizes the CVJ are the ligaments. So the joints determine the direction of motion, but the ligaments are the stabilizer of the CVJ, and there are many ligaments there. One easy way to remember them, going from anterior to posterior, divide them into 4 layers. The first layer contains the atlanto-occipital membrane. The second layer contains the apical ligament in the middle and the alar ligaments on the sides, spanning the dents to the medial aspect of the occipital condyles. The third layer constitutes the cruciate ligament with its transverse atlantal and superior and inferior cruise components. And the last layer, which is the continuation of the PLL, is the tectorial membrane. Now, most relevant ligaments that stabilize the CVJ are the alar ligaments, which limit lateral bending, axial rotation, and the transverse ligament that limits flexion. There's a lot of motion that occurs at the CVJ, occiput primarily flexion extension, while the C1, C2 joint, there's a lot of axial rotation, obviously, as well as flexion extension. And as we alluded to previously, the alar ligaments acts as a check. It limits lateral bending and axial rotation. Let's also not forget that most of the cervical lordosis is dictated by the upper cervical spine, mainly C1, C2, less so by the subaxial spine. The CVJ is very fascinating junction because it can be involved in many pathologies, and many pathological processes can involve it: congenital, mainly Chiari malformations, basal invagination, atlas simulation, osteodontoidium, inflammatory, rheumatoid arthritis, ankylosing spondylitis, infectious, neoplastic, intra-extradural, as well as traumatic, from occipital-cervical dissociations to C1, C2 fractures and combination fractures to atlantoaxial rotatory subluxations. To me, when the anatomy or the bony anatomy is simple, where the anatomic relationships are normal between the occiput C1 and C2, the decision to treatment is pretty simple. For instance, cases of Chiari malformations free from abnormal bony anatomy or occipital atlas assimilations, these are easier to treat. Intradural tumors, fractures, when the anatomy is disrupted, bony anatomy, when the relationships are disrupted, when you have autofusion, old fractures, basal invagination, cranial settling, clipal file, you got to pay more attention to the pathology such that you can give the patients the best surgical strategy and outcomes. An example on a simple, when the anatomy is normal and not disrupted, is a Chiari-1 malformation, a tonsillar ectopia causing crowding at the CVJ. Just a decompression with or without duroplasty will alleviate the symptoms. This is also another case of where the anatomy is preserved, intradural ventral meningioma. Decision-making is simple: dorsal decompression, resection of the tumor, and that's it. Now, it becomes tricky when the anatomy is abnormal, like in this situation, and even this one. This one, you would think that this is just crowding at the foramen magnum due to tonsillar ectopia. However, there's more to it. There's actually atlantoaxial instability in the setting of atlas assimilation clipal file. An old algorithm that was proposed in the past, looking at these anatomy abnormalities as reducible versus not reducible. If it's reducible through traction, then you stabilize it. If it's irreducible, you look at where the encroachment is or the compression is and address it such that if it's ventral encroachment, you decompress it ventrally and stabilize. If it's dorsal, you decompress it dorsally and stabilize. I'm going to show a few examples on reducible pathologies, and then we'll go over the rest of the algorithm and how it evolved over time, such that the ventral encroachment pathologies do not necessarily need to be addressed with ventral approaches. So this is an example. I have 3 examples to show on reducible pathologies. This is a lady with metastatic breast cancer, presents with neck pain, pretty significant, won't be alleviated unless she lays down. Was found to have diffuse metastasis, and with the index level being a pathologic fracture of C2 with causing also C1, C2 instability. You can see the subluxation here on the parasagittals. This is a reducible pathology. You can see here there's no compression, but there is a deformity. Yes, sir. Yes. Yeah. You have a question? Okay, I will continue. So this is a reducible pathology. You put the patient in traction, lock them in a vest. You can see that you reestablish the alignment normally with reduction of the subluxation, and then you can perform an occipitocervical fusion. And actually, after treatment, the bone reconstituted and the patient survived about 4 years after the operation. This is another example on reducible pathology. This is a patient who, IV drug abuser, who presented with quadriparesis, actually cruciate paralysis, that was due to atlantoaxial rotatory subluxation due to extensive destruction of the C1 and C2, as well as their joints. You can see here that's a sagittal, parasagittal views showing the destruction and the deformity that ensues after this destructive process. This is an AP or a coronal view showing both the occiput and the sagittal view and the subaxial spine and the coronal view, showing that this rotatory subluxation, how it shows up on these CT scans. And this is due to a retropharyngeal abscess causing destruction of the bone. So drastic presentation, patient 1 out of 5 of the uppers, 2 out of 5 of the lowers. What to do with this patient? The instability is causing the deformity. So place the patient in traction, 15, 20 pounds. You realign the CVJ because it's pretty loose and it's easy to realign. You can see here with realignment, you're decompressing the spine. Doesn't become an emergent. It's not an emergency anymore. Although it has a deficit, immediately the patient started getting better, regained a lot of his function, and then the next day you can take the patient to the operating room and stabilize him or her. You can see here with traction how you can achieve reduction. It's a team effort, obviously. Awake fiber optic intubation due to the retropharyngeal abscess. The airway takes precedence here too. And then you perform the OC fusion. This is another case of reducible pathology. This patient presented with headaches, upper neck pain, in addition to upper and lower extremity weakness, absent gag and cough. And you see this, you look at the syrinx and you say, okay, there's crowding at the foramen magnum. Let's just do a decompression, duroplasty, and take care of it. However, if you look closely at the bony anatomy, it's not the crowding at the CVJ that's causing the syrinx. It's actually the instability. You can see here, this is an occipitalized C1, or the atlas is assimilated cranially, and then the views, the parasagittal views, would show that the patient also has a clipal file. C2 and C3 are autofused, creating a big moment about the atlantoaxial joint. If you do a flexion extension MRI, you can see here there's anterior translation of C1 relative to C2, and it reduces an extension. So the syrinx here is actually due to instability. And the treatment of a decompression duroplasty would probably compromise the patient's symptoms and lead to a worse outcome. So part of the treatment is an stabilization, occipitocervical fusion, in addition to the decompression and duroplasty. You can see here that the syrinx has improved and the patient's symptoms also nearly resolved, including the headaches. So we showed a few examples on reducible pathologies. Let's talk about the rest of the algorithm. So if you have a ventral encroachment or a retroodontoid collection, should we go ventrally? The old algorithm says yes. However, understanding the pathology would lead to different conclusions. So classically, ventral pathology, you attack it either through an endoscopic endonasal approach, transoral, or a high cervical retropharyngeal approach. That holds true to some pathologists, but not all. Understanding the pathology made us better understand how to address ventral pathologies. And then there are efforts that we utilize these days that would obviate ventral decompression, including pre-op traction, intraoperative traction, and neuromuscular blockade, as well as intraoperative reduction techniques. This is a lady with rheumatoid arthritis who presented with neck pain and also quadriparesis. And you can see here, she has a retroodontoid, a rheumatoid pannus, She also has in the subaxial spine compression. So understanding the pathology would lead us to not address the pathology anteriorly. So the inflammation leads to ligamentous laxity, atlantoaxial subluxation. Further inflammation would create a retroodontoid pannus, further instability, and hence compression. So this lady underwent a decompression and OC fusion with resolution of the pannus, since the pannus is the result of instability due to the inflammation. Here's another case of CPPD on the left side. Patient presented with upper extremity weakness. You can see here on the image that there is a retroodontoid collection or pannus, probably compatible with CPPD. The treatment is a dorsal decompression and fusion, and then you can see that the CPPD collection would resolve. So we gave some examples on understanding the pathology would lead to the appropriate treatment. Let's look at different techniques that would obviate eventual decompression. First one is use of preoperative traction. Here's a patient who never had an issue, suffered the fall, and then presented with cruciate paralysis, upper extremity weakness, dysphagia, and presented the trauma bay. And this is a CAT scan. It didn't show any fractures. However, it showed a pre-existing congenital problem with the upper cervical spine, or the CVJ. He has both cranial settling and also clipal file, autofusion of C2 and C3. And although this condition is congenital, it can progress in adulthood because you have a big lever arm, which is an occipitalized atlas, cranial to the atlantoaxial joint, and caudally you have another lever arm, which is the autofused C2 to C3. So with time, this would create more motion on this flat joint. This joint is almost flat. And these patients can progress in adulthood with further cranial settling and further cervical medullary compression. This patient presented to us after a trauma, cruciate paralysis, which is the central corridor of the upper cervical spine, no fractures, but he definitely had a pre-existing condition that made him prone to becoming neurologically compromised. You can see here, this is the MRI showing signal cord change that explained his cruciate paralysis symptoms. So what do we do about this patient? We put the patient in traction, and we can realign the cervical, upper cervical spine. You can see here, there the before and after traction. And this is, I think, in my view, enough reduction that does not warrant a ventral decompression. So you put him in traction, lock him in a vest, and then do an OC fusion. With distraction too, there's the opportunity to get into the atlantoaxial joint and fill it with bone graft, such that this patient would improve his chances of fusion and also would decrease his chances of resettling. This man had a good outcome. Another technique we utilize sometimes is intraoperative traction and neuromuscular blockade to loosen the muscles in the upper cervical spine and cervical musculature that can aid in intraoperative reduction. And we studied that in the past in pediatric patients. We had this patient who is a rare case. She's a patient who underwent a Chiari decompression elsewhere, reportedly, and then woke up with this cock robin head. She had a carotid artery dissection causing malignant stroke, requiring a hemicraniectomy, and she also had the vertebral artery dissection. So we don't know the mechanism of how this happened. However, I saw her after 4 months after she was transferred to rehab. She came, I was consulted to see her in rehab, and she has this cock robin head, which is really stiff, would not definitely budge with any traction or any muscle relaxation. And she had a rotatory subluxation. No fractures, but a rotatory subluxation. So this patient would not budge with preoperative traction, and an anterior release of the C1 arch going from the front and release the joints is a big endeavor, especially in this situation. She has one functioning carotid artery and one functioning vertebral artery. So we thought we'd try neuromuscular blockade, only watching the SSEPs. Definitely, this is something that is risky. So we placed her under general anesthesia, we placed her in traction, and slowly she started reducing. And then we obtained an intraoperative CT that showed that the reduction was adequate. We locked her in a vest just to make sure that she's neurologically doing well. And then this is further confirmation of the reduction of the rotatory subluxation. Then we locked her in OC fusion. I elected to go to the occiput and do multiple points of fixation just because for better biomechanics in this particular patient. Maybe it was an overkill. She had an excellent outcome. Here, I will also end by showing a couple more cases here. This is a patient, 22-year-old gentleman who presented initially with horizontal nystagmus. Then he was worked up and was found to have significant pathology at the CVJ. We offered him a treatment, then he was scared, disappeared for 2 years. He came back with worsening symptoms of gait imbalance, upper and lower upper extremity weakness, numbness. On exam, he had weakness in upper extremities, and he had an absent cuff and gag reflexes, and also he had brisk reflexes in the uppers and lowers. And this individual definitely, you can see, has multiple congenital abnormalities. You can count many. Has a flat skull base, and has cranial settling. He has crowding at the upper cervical spine, and has autofusion to Klippel 5. You can see the cranial settling. In this. Is that a question or just unmuted?
Sorry, it was unmuted, sorry.
Okay, no problem. So, so you can see here the pathology that explains the patient's symptoms. The atlas simulation, Klippel 5, cranial settling, crowding at the CVJ. You can see the skull base angle should be less than 143. It's definitely obtuse. The clival canal angle should be less than 150. It's definitely, more than 150. It's definitely much less than that. And classically, these kind of patients would undergo a ventral decompression and then an OC fusion. In this situation, we try to utilize the things that we have in our bag to obviate a ventral decompression and see if that would work. And we utilized preoperative traction and also intraoperative reduction techniques. So we placed the patient in traction. That was before traction on the left side. After traction, it improved a little bit in terms of the reduction, but not perfect yet. And then we utilized an intraoperative technique developed initially by Dr. Goel and then by Dr. Walensky and Gokaslan. You can see here with the traction, we improved, we reduced a bit the cranial settling, and we improved the clival canal angle. And that's the patient here positioned for the posterior OC fusion and intraoperative reduction. So with intraoperative reduction, we're aiming at, with distraction techniques, pushing the odontoid dents caudally, and with compression, pushing the dents anteriorly. And key in achieving that is to get into that atlantoaxial joint and release the capsules and get into it and loosen it. So this is, you can, and this way you can maximize the utility of any intraoperative reduction technique. So what you do is you decompress, loosen the joint, and then you instrument, you put your occipital plate and then lateral mass screws, or if you have fixation point in C2 and C1, you can certainly do that. And the first step is you contour the rods, make them really longer rods, and you put a C-clamp cranially, and then you keep the lateral mass screws, set screws loose. This way you can distract, pushing the dents caudally. Then you lock in your lateral mass screw heads, set screws, and then you with ventral compression, with compression, you move the dents anteriorly. So you can lock in the C-clamp, keep those screws loose, and then and then you, this way with compression, you push the dents anteriorly. And this is a video here demonstrating just part of it. You can see here, see the contour rods are real long. And here we're distracting. You need maybe a centimeter or centimeter and a half of distraction. And then do the same on the other side. And then you put your C-clamps and compress them to push the dents anteriorly. And this is the end result. You can definitely, any space you find, you can put a bone graft in there to augment your fusion and improve your fusion rates. And this looks better. The patient got better. Definitely the plan would be if there is still patient symptomatic, then we definitely need to go anteriorly and remove the compression anteriorly, but he was doing well. Now let's not forget that definitely ventral pathologies sometimes require anterior approaches. This is a patient with a significant compression ventrally and causing signal cord change and necessitating an endonasal approach resection. It turns out to be an infection and a stabilization. Definitely the algorithm is more involved now, understanding the pathologies and using whatever you have in your armamentarium in terms of reduction techniques, pre-op traction, intra-op use of neuromuscular relaxation to obviate a ventral approach, and definitely leaving ventral approaches as a last resort. One thing I want to mention here is this is an OC dissociation, a traumatic OC dissociation where all the ligaments are disrupted. This is a patient that you don't want to put in traction. Although it's a dislocation, traction would definitely worsen the patient's condition, since this is a significant situation of instability where all the ligaments are torn front and back. So although it's a dislocation, this patient needs occiput cervical fusion. You can place them in a crown halo vest, but no traction. That's all I have, and I'm open to questions.
Thank you, Sir, for this great presentation. 2 questions on chat. First one. Thanks for very fruitful lecture. My question regarding your experience in CSF leak after carry decompression. How to manage it? If failed, tight dual repair or dual seal?
So I mean, if the leak is symptomatic, leaking through the skin, it's a revision. We go in, open it up, and patch it, and then we can definitely divert, use lumbar drainage to divert CSF so that our closure would seal. But sometimes if it's a contained leak and not too symptomatic, we've, for instance, I had a patient who had really not a huge pseudomeningocele, but she had some hygromas. I was able to manage it with Diamox. But certainly any leak it's leakage through the skin, CSF through the skin, my hands, I have a low threshold of taking the patient to the operating room, exploring and revising the closure, and then diverting CSF with a lumbar drain.
Second question, interesting bony reconstruction after RT for bread myths. Would you remove the occipital fixation when this happens?
So if I achieve a fusion, would I remove the occipital fixation? Is that the question?
Yes.
Not necessarily.
Myths. If you find myths.
Yeah.
If the case where the bony reconstitution after radiation therapy in metastasis for the C2 was an interesting case. So my question is, if the bone reforms, would you remove the plate to regain the motion?
So that's a great question. I did not do that in this setting, since the patient had radiation therapy and, you know, concern for wound healing after another revised surgery. I did not do that, but definitely that's interesting because the bone reconstituted, and definitely she didn't achieve a fusion, but the bone from within reconstituted, but she did not achieve an OC fusion with this. So certainly one can think about it. And my threshold of reoperating in patients with metastasis is very, very high. Unless it's really warranted in terms of a wound revision, I'll do that. But for just the removal of hardware, I won't do. Plus, I'm not sure if really the atlantoaxial joint is stable enough for me to remove the hardware.
Nadir, can I make some comments?
Yes, sir, Dr. Gowal.
Yeah, that was a wonderful presentation, and I can see that you are now slowly, surely, but definitely going from decompression to fixation. I can see that. Particularly for Chiari malformation, you identified atlantoaxial instability and you preferred stabilization. And I'm sure that as you go further in the field of, I can see your work on Chiari, and I can tell you for sure that as you go further in your experience with Chiari, you will definitely go for fixation in all the cases, even when you don't see atlantoaxial instability on dynamic images. I will recommend that you must see the facets in these cases, and the facets are more often malaligned. And even when they are not malaligned, presence of Chiari and presence of serines, as you mentioned, are clear-cut indicators of atlantoaxial instability, and you need to do atlantoaxial stabilization. That is point number one, Nadir. Second point is, you have included in cases of assimilation of Atlas and C2-3 fusion, a number of extra bones which could have been easily avoided, like you included occipital bone and several occipital or subaxial segments. I have completely abandoned occipital inclusion of the occipital bone and subaxial spinal segments. The bottom line in these cases is that you have to achieve a very solid C1, C2 fixation. And as you mentioned, we have to open the joint, we have to introduce bone graft in the joint, and then do solid fixation. The other thing that you mentioned and that intrigued me and made me happy was that retroodontoid calcification you identified with atlantoaxial instability, and you preferred to do stabilization without touching the retroodontoid tissue. And that is a very important thing, that these are secondary to atlantoaxial instability, and you don't have to actually touch these things that you mentioned. But you still did decompression because you are still afraid of this compression. And as you will mature further into this business, I can tell you for sure that you will find this region so much unstable that there will be no need for decompression in these cases. And I'm sure that you will not do decompression in the future. All in all, a very interesting presentation. Atlantoaxial instability is a very common clinical entity. I have said repeatedly that atlantoaxial instability is the most under-recognized and under-treated clinical entity in the subject of spine. There are so many things we don't understand about atlantoaxial instability. Atlantoaxial instability can be present even when the radiology is not showing the instability. So this is a new paradigm shift in the understanding of atlantoaxial instability, that it can be unstable even when there is no radiological instability. Such instability manifests as a chronic syndrome, chronic instability, relentlessly progressive symptoms, which are so much relentlessly and ultimately disabling symptoms. So we have to understand this issue of instability without radiological demonstration, and which will be a new field in the subject of craniovertebral junction. Thank you very much, Nadir, and I wish you all the best, and I am sure you will progress further in this business of craniovertebral junction.
Thank you so much, Dr. Gowal. I'm really honored.
Thank you. Thank you.
Thank you so much, Dr. Goel, for your comments. Thank you, Nadir, for your excellent presentation and algorithm. And now is the last but not least, Professor Dr. Nicholas Theodore. Professor Dr. Nicholas Theodore is actually Professor of Orthopedics, Professor of Neurosurgery, Professor of Pediatrics, and the Professor of Biomedical Engineer. And he's the Chief of Neurosurgical Spine Center at Johns Hopkins. He will present us the engineering and the future of spine surgery. We are happy to have you, Professor Nicholas, between us, highlighting the coming future in the spine surgery. Please.
Thank you.
Can you share your screen?
I can't, it says I'm viewing your screen, so you may have to release. There you go.
Samah, you need to stop sharing your screen.
Okay. Done.
There we go. All right, can you hear me and can you see the screen?
Yes.
Okay. So, well, thank you very much for the opportunity to come
Yes, it's okay.
and speak with you this morning. I'm going to talk this morning for that to close out the session here. And that was a beautiful discussion, and see my friends here, Professor Goel, Nader, and John Shin, Mohammed, everybody, to Alan Levy on the call this morning. What we're going to talk about now is really sort of what I think will be the next chapter in spinal surgery. And we've gotten very good doing things by hand, but the reality is I think that we can do better. And while I don't think we're going to get to the point as in this movie where the robot is doing the entire surgery, there are definitely advances that we can use today that I think can help make us more efficient in what we do. Let's see, so my disclosures. And this is where I am right now. I'm in Baltimore, and in the middle here is the iconic Johns Hopkins Hospital. On the right is the patient care tower, and on the left is the old operating rooms. And what you see in the middle here is where surgery, in at least in America, the birthplace of American neurosurgery with Harvey Cushing and Walter Dandy took place, and that's the Carnegie Building. And on the seventh floor, I should say, the Carnegie Building were really the old operating rooms for over 100 years in Baltimore, and where Dandy did pneumoencephalography, where brain tumors were taken out, and really where things first got their start in neurosurgery. And one of the interesting things is that this space now has been converted into an engineering space. So you can see the old operating room here, wheeling in the bed, now the O-arms being wheeled in. And the old operating room now at Johns Hopkins has been transformed into the Carnegie Center for Surgical Innovation. And really it is a hotbed for technology, 3D printing, surgical training, machine shop with everything that you could imagine. As a field in neurosurgery, obviously, we've been very beholden to technology, and we really have pushed the envelope when it comes to technology. This is Walter Dandy utilizing a ventriculoscope in the early 1900s. And interestingly enough, since there was no ventriculoscope, Dandy used the endoscope that he borrowed from his urologic colleagues, from the urologists at Johns Hopkins. Hopefully he washed the scopes before he used them. But the reality is, again, always looking to forward our field. Imagine what we would be like without technology like the Bovie. And this is Cushing and one of his first operations utilizing the Bovie. On the left is William T. Bovie, who was an engineer. And it's that teamwork between engineers and surgeons, especially in neurosurgery, that really has driven our field. And I'd argue that those changes and advances are what's going to push us into the next century. This is James Greenwood. Once again, imagine doing surgery today without the bipolar. He was a ham radio operator from Houston who realized that by electrifying the forceps, we could get coagulation to run through them and very elegantly seal blood vessels. Again, it's transformative in our field. Theodore Kersey with the operating microscope at UCLA. This is Jose Delgado. Do you want to talk about being a little crazy? He was taking an electrode, this is back in the early 1960s, and planting it into the brain of a bull, then letting the bull loose, and then pushing a button on the device, causing the bull to avert and not charge. Great experiment. I don't know if I want to be the one with in the ring with the bull, but the reality is, again, this was the birthplace of deep brain stimulation. We got to a certain point around 1970 when it was very interesting, and neurosurgery was a difficult specialty. Outcomes weren't great. And Richard Berglund came out with this article in the New England Journal, Neurosurgery May Die. And he basically said that because it's a lack of interest in technology, that the field in and of itself was going to go away. Thankfully, he was wrong about that. What we have seen since that time is that an explosion in technology in neurosurgery. When you look at the patents issued in neurosurgery between 1960 and 2010, there are over 11,000 distinct patents issued, 200,000 publications. and patents around image guidance, motor evoked potentials, microscopes, endoscopes. We really is a fertile birthplace for advances in technology. And this dates back to over 100 years with Victor Horsley attempting to use stereotaxy in the brain. How do we have these, very ornate setups now which are all in the museum to allow us to navigate? And all of those factors really came into play in lockstep with imaging. And it really, I would argue that the advances in imaging really have changed our field. Think about that in neurosurgery. Think about Nader's talk just now, not being able to have an MRI or a CT. We have no idea what was going on with these patients. That really has transformed our field and elevated what we're able to do. And you can see that with MR and CT, both Nobel Prize winning technologies, has changed our field. Really, with Dave Roberts and his group at Vermont, the advent of bringing in this, the ability to marry a medical image in surgery, I would argue would probably be one of the biggest changes that we've had in neurosurgery. This is Watanabe utilizing the first frame-based stereotaxy. But again, think about this for one moment. Obviously, in the brain, being able to know where you are has changed fundamentally what we do. And it has in spine surgery as well. Part of the issue though, and I was doing my training when this technology was first coming out, the reality is what I notice is everybody's distracted. You're touching the medulla or the brainstem and everybody's head is focused in another direction. And when we do this in spine, it was the same. And this is a case I did probably 15 years ago now, when we were published a series of upper thoracic percutaneous instrumentation. And again, you have to believe and you have to understand that technology to be able to do something like this without having the visual landmarks. But again, look at where everybody's attention is focused. Nobody's looking at the patient. We're all looking at the monitor. Why is it important? What are we looking for with image guidance? What we're looking for is high accuracy and high precision. We're looking for the ability to hit that target every time. And I would argue that based on where we are right now, we can definitely improve upon our technique and our numbers. We've looked at this extensively at Hopkins and at other places. When you look at the experience at Hopkins, this is back in 2010, about 9% of the screws had some sort of breach. Now, thankfully, most of those breaches of pedicle screw placement are not symptomatic, thank God. But again, 9%. We look at large meta-analyses done, we realize a couple things. One, that when you start adding imaging, whether it's fluoroscopy or 3D imaging with image guidance, your accuracy improves. And this is a summation here. Conventional accuracy or freehand, again, about 68% accurate overall. When we start adding 2D and fluoroscopy, we get up to 84%. When we start adding 3D, we get into the 95 percentile range. Again, really able to raise our game. And why would you want to use this? Why do you want to do this? A couple of reasons. Obviously, decreasing malpositioned screws is a huge interest. We don't want to hurt a patient. We don't want that to happen. We want our screws to go in accurately. The study out of the Cleveland Clinic showed that there was a decrease in hospital stay when image guidance was used, and also decrease in spine-related admissions from complications. And then, of course, a decrease, as you would imagine, from having to change your hardware. Utilizing that image guidance up front gives us the confidence to place hardware and not have to go back to change it.
He just got reinstated. Well, not official. Nervous? Yeah. Me too. Don't worry about it. We'll figure it out. I'll see you in there.
So the question is it okay to be okay? In other words, is 90% accuracy okay? Maybe, but the reality is it takes but one misplaced screw to ruin your or somebody else's life. And this was a scoliosis case, had a multi-$100 million settlement here. But the reality is, again, we want to avoid that. So where are we right now? What happened? So between 1996, 2013, only about 13% of spine surgeons This is a worldwide survey. We're utilizing image guidance. And there's a lot of reasons for that technology, having to do with financial constraints and such. But there's why is that adoption rate? Well, part of the reason was that for a surgeon, we didn't want to be slowed down. We didn't want to have a situation where our workflow was impeded. So we felt, well, we can do this. We don't need defining technology. We're good enough as we were. And that's where things got lost. This number now is probably 25%, approaching 30%. As spine surgeons, interestingly enough, we're always a little bit behind the eight ball. And I show my cranial colleagues here that we're carrying the old compact 8064 computer on our back, and my colleagues in cranial surgery have the iPhone, but we're getting to that point. Right now, we're at a nexus. We've had significant advances in imaging, in surgery, and robotics. Obviously, image-guided surgery now has been part of our armamentarium for over 30 years. And the melding of surgery and robotics has definitely come into the operating room with Da Vinci and other surgical robotic platforms. But I would say that right now, there's a melding of image-guided surgical robotics and the ability to take a medical image to guide us to help perform a procedure. If you talk about automation in surgery, you can go back right now to 1980 in Russia, and this is the Fyodorov Institute. Fyodorov was doing radiokeratotomy, and he thought, why do I have to go and do an operation and then go to another operating room? Why can't I sit down and have the patient come to me? And he was doing thousands of these operations. And what he found was that if you don't have to get up and move around and change your position, you're able to be very efficient, and you're able to really take care of a large number of patients. Now, imagine doing this in the United States or Egypt or anywhere right now. Probably not going to happen. But he interestingly died in a very mysterious plane crash attributed to the KGB. We're not going to really know the story of what happened to him, but certainly ahead of his time when it comes to automating surgery. When we talk about robots, everybody's afraid. I guess even the Pope is afraid. Pray that the robots don't turn against us. This is from a couple months ago. The first surgical robot came out in the 1980s. This is the Puma surgical robot for stereotactic depth electrodes, really never caught on. This is Russ Taylor from Johns Hopkins, one of my colleagues who had the first commercialized robot, the RoboDoc, for coring of the femoral shaft in orthopedics, and actually commercialized. Again, didn't really become overly successful, but really was way ahead of its time. This is the ASOP, and the ASOP is a device that really all it did was hold an endoscope. And this, I will tell you, was the first usage. This robot was first used in spine surgery, and this is 1995. This is Curtis Dickman, who was one of my mentors in Phoenix, and we were doing a lot of thoracoscopic surgery. And as a resident, my job was to hold the endoscope for 8 hours during surgery. So I was very happy when this robot came along, because it meant that I didn't have to hold the endoscope. But again, this is something that was, had not been done before, certainly not in spine surgery. The military had a great interest in refining this technology as well, because they wanted to be able to operate on a patient somewhere else. So the patient is in a forward field hospital somewhere, the surgeon can stay back. And interestingly enough, all of that technology that became the Da Vinci was born out of DARPA and money from the government to build this device. After it was built, the problem was that it didn't work. And why didn't it work? Because of bandwidth. So we realized after this was built for its first iteration that we couldn't operate on somebody overseas because the internet connection wasn't fast enough. Well, that's certainly gotten better, and certainly that's why we're all on this call today. Otherwise, it wouldn't be possible. But this technology has changed general surgery and cavitary surgery. This is John Adler, and this is the CyberKnife, another example of stereotactic robotic guided radiosurgery. I found this very interesting. This is a robot. So what is this guy doing? It's for hair transplant. So we've got robots now for everything in medicine. This is the ROSA robot, and this is a robot that's been used to deliver stereotactic electrodes into the brain. And just a word of note, this is the Mako robot. This is a robot now that was purchased by Stryker, and it's really used to perform knee, hemi-knee, and total knee arthroplasty. And it allows the surgeon to jig the knee with sub-millimeter accuracy. And we're going to come back to the importance of that accuracy, because most of the orthopedic surgeons who use this technology have said, why do I need this? I can jig a knee in 40 minutes. I don't need a robot. But we'll come back to this at the end. So just remember this. And then this is most recently, this is Johnson & Johnson's Auris robot. This is a flexible robot, a snake robot. Imagine this going through the bronchial tree and able to do endobronchial biopsies. And this is something that is really, again, going to transform that field. When we talk about robots, especially in spine surgery, we're not really talking about fully autonomous robots. We're talking about cobots, and these are devices that work side by side us in the operating room, allowing us to become more efficient. We don't want to have to stand by and have the robot do everything while we're just watching the operation. Obviously, we want to be involved, and that's where these technologies can certainly help us in what we do. And what we're looking for in spine surgery is reproducing that accuracy. And this, you don't want to be playing this robot in darts in a pub in Ireland because you're going to lose. Look in the lower left-hand corner. Every throw of that arm hits a bullseye, a perfect bullseye. And this is what we're looking for in spine surgery, I would argue, is just automating that our accuracy, taking some of the more mundane things we do and automating that process. If we use the analogy of NASCAR, this is 1964. You see the car pulling into the rest stop. He slows down. The crew pit team comes out. They're doing a little body work here, changing the tires. Well, the fender's broken. The driver says, "Can you fix that?" "Yeah, we can fix that. Let's just go ahead and hammer that in a little bit with our shoe." And, this could take 2 to 3 minutes to do. And when you go back in pedicle screws and open spine surgery, the 1984, again, we start learning. We see the anatomy, we feel the pedicle, we palpate. And this is what we're doing in open surgery. And, again, knowing your anatomy, skilled, but open surgery. And again, as good as you are in revision cases, the anatomy can be obscured. We get to 2016, we see this same pit stop now with a change of 4 tires, change of the oil, change of other components, filling up the gas. And this takes about 12 seconds. And that is really, where we have gotten in NASCAR. Now I will tell you that, placing screws for an MIS pedicle screw case takes less than 5 minutes at this point from you. We've got the defining technology with robotics now, where I can actually have the robot come into the field and put my screws in for a minimally invasive TLIF in less than 5 minutes. So again, using NASCAR as an analogy, we can do a lot better in what we're doing. This concept of robotics really first came to me, and this is 2002. Volker Sonntag, my mentor, was the honored guest at the Congress of Neurologic Surgeons. We were talking about what the future was going to look like, and I came up with this cartoon of this is what I thought things would look like, and again, realizing that we're not anywhere near this, where the FDA is not going to allow us to do autonomous surgery. But that was the thought at the time. How do we automate what we do? And why do we need robotics, or want robotics for that matter? Well, ultimately, obviously, patients are looking for less invasive surgery. We as surgeons want to reduce our radiation exposure for ourselves and our patients, and we want to be really consistent. And we also want to be able to use preoperative planning. Part of the problem with radiation exposure, obviously, is that you can't see it or smell it or taste it. And this radiation source is a huge public health concern, especially to us as spine surgeons. When you look at studies that have been done, our exposure increases us potentially to a significant 5 times increased risk of cancer for continuous usage of fluoroscopy. And this applies to my colleagues in endovascular surgery. And that is even when you're using a thyroid shield. So even with the usage of protective equipment such as a thyroid shield, the fact of the matter is it only takes out about 2/3 of the radiation. So this is me earlier this year throwing away my lead. I'm done. I'm not using lead anymore. Imaging is done without me in the room. So my radiation exposure is now 0. I started this interest in robotics over 20 years ago, and this is the lab in Phoenix when I was a resident at the Barrow Neurologic Institute. And you see the ASOP arm attached to the table, and the question was, could we utilize a robot to target the pedicle under fluoroscopic guidance? And this is Neil Crawford, who's my best friend and biomedical engineer. And we were able to take that concept and go back and forth over a period of 10 or 15 years to the point where we were able to build a working prototype of a robot. And this is the prototype here that we started off with 6 axes of rotation, and allowing us to, in real time, utilize image guidance to perform surgery. And the importance of having real-time image guidance is what happens if the patient moves? What happens if the patient coughs or settles in the table? Well, the robot will respond to that. And we built it from the ground up with that ability to move in real time. This is 2012. This is the first cadaveric, pedicle screw cannulation. See, I look a lot younger at that time. And the reality is I was a huge aha moment. We were able to target the pedicle with extreme accuracy. And I realized at that moment that we're going to be able to, in real time, target the pedicle and perform robotic surgery. And it took a few years, but in August of 2017, the product was commercialized and we were able to do our first case. When you talk about design and what you're looking for in the usage of this technology is not to go backwards. Obviously, workflow is key, and also having image guidance. So if you're taking a tumor out, being able to navigate around critical structures and use the robotic interface is critical. Where it sits in the room is also important so that we're not crowded. The residents were worried, but you can see the robot's out of the way. I've got myself an assistant, and there's no worries about that. And how do you design this such that it can fit into workflow? Well, in this case, we can use the robot with just fluoroscopy, preoperative CT, or intraoperative CT with the O-arm. Any one of those paradigms works, so you can adapt that to your own workflow. And then, of course, getting feedback when something changes, when there's a loss of registration. In the cranial surgery, if something moves and your probe is not in the right place, that can have catastrophic consequences. So in the spine as well. So knowing that our accuracy has high fidelity and knowing that we're getting forced feedback is important. Probably one of the more stressful days of my life, October 14th, 2017. This is the first case we did at Johns Hopkins. And in the room was the dean of the medical school, my chairman, about 40 other neurosurgeons, and everybody watching, and sweats beating down my head. And I was thinking to myself, well, if this doesn't work, I'm going to be in trouble. And the robot I kept pointing to L5 and it kept going to L4. And I was like, well, this is it. I'm done. This is over. Turns out the robot was perfectly right. Our incision was off. So once again, now we're using the robot even to plan our incisions. But now with close to 500 cases under my belt and over 60,000 cases worldwide, because the technology is moving. How do you use it? It's very intuitive. You're able to plan preoperatively or intraoperatively your trajectories. And you can see in the lower left-hand corner, as you're doing a single level case or a scoliosis case, making sure that everything lines up. Taking and using the best corridor for anatomy. You can't do that freehand. You can't find out exactly where you are. Knowing to avoid the adjacent level facet. And I would argue that that may indeed help decrease adjacent level disease going forward. Robot comes into the field. And this is, again, at the beginning of the case, utilizing the robot to plan your incision. Now we make tiny incisions because I'm not making an incision based on guesswork. And remember the old days of minimally invasive surgery. We had the x-ray and we're drawing all these lines on the patient and tattooing them. It looks like a Cartesian coordinates on their back. Again, small incisions, and within the first several minutes, all the hardware is placed. Show you just a few cases here from the last couple of years. This is a woman from Baltimore with osteomyelitis and progressive deformity. And again, utilizing the robot twofold. One is obviously to place the hardware seamlessly, but secondly, obviously to navigate removal of bone and resection of the kyphus and vertebral column resection to restore alignment. This is a young girl. We've just published a series. This is a girl with tethered cord lipomyelomeningocele. It had 6 prior surgeries. See, the cord is stuck down here, getting progressive weakness and pain. And obviously, this is what we used to do, which is to do a detethering of the spinal cord, going down to the bottom and loosening everything up. This takes hours. The patients are unhappy. There's a high rate of CSF leak, not the most gratifying operation. The question is, and I've become enamored with, and we can talk about this at another time, but doing a vertebral column resection, actually taking out 70 or 80% of T12 and shortening the patient by about 24 to 26 millimeters, taking the tension off the spinal cord. And interestingly enough, now again, this is open access neurosurgery, March of this year, 2021. The article just came out. These are the figures here showing this partial vertebrectomy of T12. This is that patient in question. Look at the pedicles. Again, the issue here is, putting instrumentation in by hand can be difficult with pedicle expansion. We were able to get the screws in nicely, and you can see the vertebral column shortening here. And this, I think, really, convinced me here as we do this. We've been using ultrasound a lot, and we look at this, and you look at the excursion of the spinal cord, and then look at after surgery. So we see an actual increase in the diameter of the spinal cord and the pulsatility of the spinal cord after we shorten it. And neurologically, this patient improved significantly and is doing great. And this is just one of the figures from the paper, but we did show sustained improvement in pain and function in these patients over a course of years. There's another girl who'd had, unfortunately, a couple of laminectomies and in situ fusions for a progressive deformity. Again, you've got this here, scar tissue, high body mass index. And rather than attempting to reduce this because of everything the way it was, fixing her in situ with a transvertebral screw and getting her into alignment was, I thought, a better option. Again, using corridors that we don't actually normally use with image guidance from robotics has changed things. This is a patient with a T8, fracture instability, high body mass index, Jehovah's Witness, and, very ill medically. Fixing this highly unstable fracture, is probably not going to be done in somebody whose hemoglobin is 7.6, but unfortunately, we're not able to mobilize this patient otherwise. We were able to get him fixed in about an hour, and his pre-op hemoglobin was 7.6 and post-op 7.4. Again, utilizing this technology to help us tackle some of the more difficult cases. This is a hybrid surgery where we put the screws in through the fascia and then decompress the spinal cord for multiple myeloma. This is an upper thoracic case in a young girl with a destructive process here. Again, being able to lessen what we need to do through open exposure. I will tell you that we have a new paradigm now, I think, of accuracy. And we're not going to say anymore, are we in the pedicle? Are we out of the pedicle? We're beyond that now. Now we can say, here's what we planned. This is what we placed. And did we hit the target? And when you look at Gertzbein Robbins, and this is what we were held to for the past 40 years, really was, are we in the pedicle? Are we okay? Are we in bone? It doesn't really know where we wanted to be or where we intended to be. It's just the question is, where did we end up? And this is one of our first publications. And is everything perfect? No, it's not. Look at D. There's a parallel screw placement from where we planned it. And this had to do with deflection of the drill tip. And we've learned a lot now and are refining our drilling techniques, so this doesn't happen very much anymore. But again, it's looking at this accuracy. We published this about a year ago. This is a three-dimensional volumetric analysis of accuracy. Again, raising the bar. It's not now about, is the screw in, but is the screw in exactly where we want it to be? What's the deflection? How do we get better at what we do? So, imagine this is really the highest bar you can have because you've planned exactly where you want to be, and are you hitting that target? So let's go back for 1 second. We're going to talk about our colleagues in orthopedic surgery with knee arthroplasty. And utilizing this technology over the course of 5 years, what they found was that the patients who had the robotic assisted placement of the knee arthroplasty were doing much better at 5 years. They had less mechanical access outliers, which is bad, and less joint layer access outliers, which is bad as well. And the satisfaction was much higher. Why is that? Because it's perfect. Once that knee is jigged with the robot, the implant fits perfectly. Now, the master surgeon does very good, but again, and even in this case, with comparative case, not doing as well as the robot. And in our case in spine, I would argue that we're staying away from the facet joint. We can put bigger screws in. One of the things I found now utilizing robotics is that the screws are much larger, and I can put longer screws in. I don't say, give me a 5.5/40 anymore. It's give me a 7.5/50 because I've measured out exactly where things are going to go. One of the issues with all of this technology is that there's a learning curve. And, we found that out. And this is a series that we published here just about a year and a half ago with some of our first 28 cases compared to controls. Interestingly enough, the more MIS approach, we did have less blood loss and length of stay, but it was about 4.5 minutes a case. So you see at the very beginning, we were taking 3 and 4 hours to do these cases. And, you know, ultimately now we're reliably down to 2 hours or less for a single level MIS TLIP. And that is with a resident and not just a surgeon involved. And that, you know, I would argue is not bad, especially in a training environment. But again, practice makes perfect. When you look at this now in the literature, you know, the usage of robotics in spine surgery now has been graded A. This is a review article looking at all the technologies available, and this is a, you know, high degree of confidence in that what we're doing now with robotics is going to become certainly more commonplace. What else drives this? Well, my residents drive this. The millennials drive this. We don't have as much time with our trainees as we used to have because of resident hour restrictions and whatnot. And my residents embrace this type of technology. It's very exciting for them. And the fact of the matter is that, you know, they are very adept at utilizing this technology. It will become a defining concept in their training. Why do things fail? Why do technologies like this fail? Well, number 4 is probably the most important. Cost is always important, but something that slows us down. So once again, with the learning curve, building this into our armamentarium is important. And ultimately what I see is this interplay in neurosurgery and spine surgery between these defining technologies, whether it's intraop imaging and our ability to deliver focal therapy for spine tumors, for instance, being able to put our instrumentation in and deliver other chemotherapeutics, other procedures, whether it's in the brain or the spinal cord, and take what we're doing now, which is putting instrumentation in. Okay, simple, trauma, MIS applications. I'm using it now for deformity and tumor pelvic fixation. Then looking at direct lateral, tumor resection, and then ultimately bringing us into the realm where we're utilizing the robot for osteotomies and other procedures. The same technology is readily translatable into the brain, and the same platform now has FDA approval for the brain. So some of my other interests has been in, and this is again all about engineering and the spine, has been an assessment of alignment. And part of the problem is, as we all know, is that we get standing scoliosis films and they're great, but once you put the patient down in surgery, something changes. So we've now developed technology that allows us in surgery within about 10 seconds to get an assessment of somebody's curve. And I can get the parameters of pelvic incidence, lordosis, everything in about 10 or 15 seconds in real time. And as we do a correction and as we start correcting the spine and get continuous feedback as often as you'd like, you know, with these numbers. So this is technology that hopefully we'll be seeing in the operating room soon, being able to, again, figure out exactly how we're doing. Soft tissue robotics is also important. You know, having the ability for us to be in very small places is another part of our lab at Johns Hopkins. Ultrasound is, I think, going to be a very powerful technology. We'll talk about that here in a second, but utilizing ultrasound to help us update imaging is going to be, I think, part of our in our armamentarium. My colleague Amir Mambachi has been working on this, looking at utilizing ultrasound to target the pedicle and help us with pedicle screw placement. This is PhD thesis. This is also fascinating. We also have a project going on right now utilizing this MR to CT, taking a standard MRI scan and making it a CT. Now, how's that? How cool would that be, where you don't have to get a preoperative CT on the patient? Use their MRI scan and convert it into a synthetic CT. So that can be done, and I will argue that that will be done as part of our armamentarium going forward. This is another project that we just published a couple of years ago, looking at known component analysis. What we see with CT scan, obviously, especially post-op, is a tremendous amount of artifact. We get lost sometimes because if you look at F here in E with all this artifact. Interestingly enough, if the algorithm knows what the instrumentation is, what the size is and the vendor, it's very easy and very quick to be able to use what's called known component analysis. Look at these pictures now. You can actually count the threads on the screw. So our ability to use regular conventional CT is going to increase dramatically by the usage of this type of technology. Augmented reality is here right now. It's, you know, I thought it was a toy. We published on this now with Augmetics and other groups utilizing intraoperative ability for us to see where we are by putting a headset on. So taking just regular image guidance and elevating that. people ask about, well, can we plan pedicle screws automatically? And the answer is yes. So this was just done last year as well, and we're able to basically through machine learning have pedicle screws placed automatically on the phantom or on patient's CT scan, utilizing advanced techniques. The interesting thing about this is that we're going to be able to utilize your preferences. So for instance, if Dr. Shin wants his pedicle screws more medial and a more anatomic entry point, all he has to do is say that, and the machine is going to take those preferences as they plan. And also, guess what? Lining our screws up for us, making sure away from the facet. You set the parameters and the computer will do the rest. So we've taken this a step farther at looking at segmentation of vertebral bodies, again, looking for movement and alignment in the spine. And this has been another exciting aspect of our research. What about other things? So my colleagues in orthopedics and I have been working on tracking the tips of movable instruments. So you put these movable probes in for pelvic surgery, for instance, and the tip moves. Can we track a tip of an object that actually moves? And the answer is yes for that too. And ultimately, this really takes us into the realm of artificial intelligence. And this is a paper we published last year looking at, a very complex algorithm of taking high resolution imaging over the course of the patient's treatment, pre and post-op, looking at all the demographic data, and then ultimately looking at a mobile-based platform for PRO, patient-reported outcome assessment. And that basically has taken us into the predictive realm. Is somebody a candidate for surgery? What complications might we see, et cetera. So helping us define what we do in surgery. And, this is another project we're working on. Again, the intersection between ultrasound and medicine. But this is a project we just started last year, supported by DARPA. And the whole issue for us in the spine is looking at blood supply of the spinal cord. We do it in the brain. We monitor cerebral perfusion pressure. We don't do it in the spine. I published a number of years ago this paradigm of increasing mean arterial pressure and draining spinal fluid to improve perfusion. And it does work. This isn't a pig model. But it's very hard. How do we measure perfusion in the spinal cord? And I've come upon ultrasound as being, I think, the defining technology for that. So we've started a project now where we're actually looking at microvasculature of ultrasound in the spinal cord and developing a device which can be laid on the spinal cord to give us a measurement of perfusion of the spinal cord post-injury. And then with a very complicated drainage catheter, measuring temperature, pressure, and biomarkers in real time, give us an idea of how we're doing. This wouldn't just be for spinal cord, injury. We could certainly use this in scoliosis surgery, deformity surgery, Chiari surgery. Having this high resolution ultrasound at point of service, I think would have a big impact in what we do on a daily basis. So ultimately, it's about safety, it's about education, it's about taking these technologies, seeing how they fit into our own environment. Are they benefiting our patients in the long run? If we're not trying new things out, we're never going to know. So being at that nexus of engineering and surgery, I would argue is not a bad place to be. It's a complicated intersection, but technology, certainly in our field of spine surgery, has really been a critical part of what we do. This new technology is being adopted on a daily basis worldwide, and I would argue that we're not going to go backwards. We're going to continue to go forwards. It's a large team. This is part of the group at Hopkins here in a couple of slides. And the reality is that again, it's not one person's work, but this teamwork between engineers and surgeons to elevate our field. So I'd like to thank Mohammed and the group and my friends on the call here for the opportunity to address you this morning, and hope that everybody has a great day, and certainly, obviously, happy to take any questions. Thank you.
Thank you so much, Professor Theodore, for your presentation and the future of spine surgery. And I hope after a resolution of this global pandemic, we can have this technology evolution rapidly. And I hope I can do surgeries from my vacation side and operating away from the operating theater.
Mohammed, nothing better than being on the Red Sea, relaxing, and then having surgery done in Cairo. It's all good.
Exactly. And we hope this global pandemic go away soon and we can meet all of you physically here in Egypt. Uh, Actually, it is something beyond the expectation. What is the robotics can do? As you showed us in the first slide, this video, and how the robotic surgery can get rid of the aliens from inside the human being, and even they can seal the wound, and the wound is completely gone after the end of the surgery. So maybe in the near future we can hear something like this. Do you expect that?
So that's a little bit off, but I will tell you that for some of what we do, the concept of incisionless surgery is not improbable. And we look at various technologies now that are coming out that could allow us to do other things, whether it's a decompression potentially, or deliver some sort of regenerative energy to a disc, for instance, or to help a fracture heal, may mean that we are doing things without incision. So certainly that would be the highest bar to aspire to. It's going to be a while before we get to that point. I would say the next phase, at least for robotics, is going to be the addition of tools that allow us to perform osteotomies, to do our facetectomies and our decompression. And I will tell you that's coming out soon. That's not far off in the future.
We don't have questions from the participants. Anyone from the panel, Dr. Will, Dr. John, Shen, Dr. Nader, anyone who wants to comment or deliver a question?
That means I did my job, Mohammed.
Super. Thank you so much,
Of course. Of course, sir.
At the end of this webinar, I'd like to thank our great speakers from USA, Dr. Nicholas Tudor, Dr. Nader, and Dr. John Shen, Dr. Alan Levy, and Dr. John Polina. And my last word is thanks, Sameh, for your great efforts gathering these nice friends and colleagues from all over the world to deliver and spread and exchange knowledge. God bless you and stay safe, and see you in the next episodes from Egyptian and world neurosurgery community. Meet the masters in spine surgery. Thank you so much, and stay safe.
Thank you.
Bye.
Thank you, sir. Thank you, sir. I'd like to thank every professor who have joined us today and our colleagues. And I'd like to announce that we have registrations before we started this webinar, 615 participation. So if you if you didn't attend our live, you can follow the record on AWNC YouTube channel and meet you again in another session. Thank you all. Meet you again. Thank you.